Okay, well, it's 9 a.m., so I'll go ahead and introduce this morning's big block panel on ALD and AMN. Welcome to the United Leukodystrophy Foundation's 2021 Virtual Family Conference. This morning, we will be discussing ALD and AMN. We have 4 blocks of topics, and the speakers will be passing the torch to each other this morning. I want to remind everyone that this session is being recorded and will be posted for public viewing to our ULF office YouTube page. And we hope to have all of those videos available for viewing by July 15th. So we just keep in mind that we are being recorded today. And if you are seeing questions in the chat, please read the question out loud so that we can hear it on the video. Otherwise, without further ado, thank you so much for all being here with us. I will let Dr. Raymond kick it off.
Okay, good morning. I'm going to share my screen, so give me a second. Here we go. And make sure it's in presentation. Okay, good morning, everyone. So I have the honor of being the first speaker. So I'm going to actually do a little bit of intro for adrenoleukodystrophy and adrenomyeloneuropathy. And if other speakers repeat some of the stuff later on, I think repetition is great. My plan is just to talk for about 10 to 15 minutes and then turn it over to my the other speakers for this session, and let's go. So adrenoleukodystrophy falls into a group of disorders called peroxisomal disorders. And peroxisomes are fascinating organelles within our cells. And we have assembly defects as well as single protein disorders. But the most common is X-linked adrenoleukodystrophy. It is an X-linked disorder. It's on the X chromosome. It has an incidence of about 1 in 17,000, and that's actually holding up fairly well. There is no specific group who is affected with this, so all races, all ethnicities. And it's due to a defect in ABCD1, which encodes a peroxisomal ATPase binding cassette protein. And this results in a defect in peroxisomal beta oxidation and the accumulation of these unusual compounds called very long chain fatty acids. And while it affects almost all the tissues of the body, it affects predominantly the nervous system, the adrenal cortex, and some unusual cells in the testes called the Leydig cells. The gene, this is stolen from Stefan's page, it is approximately 20 kb and consists of 10 exons. And this is an older slide talking about the types of variants we can see. And one of the things that we want to continue to hone in on is that there are a lot of private or variations. And so that sometimes people come to us and go, oh, this one has never been reported before. It's called a variant of unknown significance. And we just have to kind of walk it back and say, that's not unusual. This is something we see time and time again. The diagnosis used to be made when you saw someone and you would do the very long chain fatty acids, and we still come back to that. But more and more, I'm finding that people are being diagnosed by DNA testing, either a panel or an exome. They come to attention because they either have a leukodystrophy, or they have spastic paraparesis, or they have adrenal insufficiency, and somebody's doing a panel around those things. Because of all these variations that we can see, we still need to go back and do the biochemical testing. And then now in 2021, more and more families are being diagnosed by newborn screening using dried blood spots, at least in the United States. One of the most fascinating issues around ALD or adrenoleukodystrophy is that it has a variety of different presentations. It has an asymptomatic. It can have adrenal insufficiency. It may have cerebral disease. And then the one we're talking about predominantly here today is adrenomyeloneuropathy, which occurs predominantly in 40 to 65% of individuals. And not to slight the women who are carriers, we're going to talk briefly about them also. the most important point, and I emphasize this to my residents all the time, is that making the diagnosis does not predict what form of the condition you're going to have, even within the same family. And everyone who's dealt with adrenal leukodystrophy realizes that even in the same group, brothers, one can have childhood cerebral disease and another brother may have adrenal myeloneuropathy. Similarly, one brother's presentation with adrenal myeloneuropathy does not predict what his brother's presentation is going to be. And so there's a lot of individual variation. So covering this very quickly, adrenal insufficiency is primary adrenal cortical dysfunction. It can occur acutely or chronically. We can see hypoglycemia, difficulty fighting infections, hyperpigmentation, and it's a leading cause of adrenal insufficiency in males. And the majority will develop some neurologic disease at some point in their life. So sometimes we find people going around asking, can I have just adrenal insufficiency? And the answer is probably not going to happen. This is what most people think of when they think of adrenal leukodystrophy, or at least what most neurologists think of, is this childhood cerebral disease, which we're going to be talking about in the session following it. These are boys with initially normal development, somewhere between 4 and 10 years of age. They start to have some really subtle findings and then progress rapidly from there. And this is what the MRI looks like. However, what we're talking about today, or in this session, is adrenal myeloneuropathy. And this is men and women, typically around the ages of 25, 30, who develop spastic paraparesis, sensory involvement, gradual progression. And the reason they do this is that they're developing axonal disease resulting in loss of myelin and atrophy of the spinal cord. We're going to go through some of that spinal cord anatomy because it kind of explains what's going on in the disease progression. And once again, as we talk about the myelopathy, women who are carriers, and I put carriers in quotation because women have a disease. 20 to 50% of women, and I think that's an underestimate, who are carriers will have some symptoms. Predominantly myelopathy, which is again the spinal cord disease, which we're going to get to, and peripheral neuropathy. Again, they have spastic paraparesis, they have dysesthesia, is a fancy word for change in sensation, and bladder and bowel symptoms. And this can be a function of age. It's rare, though, for women to get cerebral or adrenal disease. So kind of when we talk about adrenal myeloneuropathy, you got to learn a little bit of neuroanatomy. And we're not going to spend a lot of time doing neuroanatomy, but this is the sort of the structure of the spinal cord. There is stuff going out. I don't know if you can see my pointer, but it's leaving from what's referred to as the anterior horn and going out to the muscle. And there's also stuff coming in, sensations, things we're experiencing in our legs and our hands, and that goes up to the brain. So again, in adrenal myeloneuropathy, we have fiber tracts going down that are going to be affected, that are affecting our motor function, as well as sensation coming from the periphery and traveling up to the brain. And so when we talk about the spinal cord disease, we're going to be talking about both descending fiber tracts as well as ascending fiber tracts. And this results in dysfunction of both motor and sensory findings because of this involvement of the spinal cord. Well, what kinds of things do we see? Well, we see spastic paraparesis. This is progressive stiffness and contraction, mainly in the legs. We rarely see it involving the arms, although in some rare individuals I have seen that. The reflexes are brisk. And because the reflexes are brisk, we see something called clonus, where they spontaneously jump. And and these are all normal functions. And to some extent, we have these reflex arcs for a purpose, but they're all exacerbated. So, rather than keeping it all under control, now they're all in less control. It eventually leads to weakness. And with this weakness, we get difficulty with walking. With difficulty with walking, you get falls, you get fractures, you get other problems. In addition, again, Proprioception is knowing where your body is in space, so to speak. It's position sense. And so we start to see sensory problems. And because our bladders and our bowels also need these inputs from both the sensory as well as the motor functions, we start to see bladder and bowel incontinence. Now we can rate these things over time. Some of the scales that we use, and hopefully we'll be talking in some of these sessions about some other things that we can use. We can use a scale that was essentially set up for multiple sclerosis. This is called the Extended Disability Status Scale. It's not particularly linear. It was set up for multiple sclerosis. We use it, but it's not particularly an ALD scale. In some studies, a modified Rankin scale, that's another scale, has been used to look at severity. Dr. Kohler has set up the adult ALD clinical scale, and that's a scale from 0 to 24, and that's significant utility, partially because it also talks about the cerebral dysfunction. And there's this orthopedic scale that I'm not a particular fan of, the SSPROM, and that's been also used in some studies. So you'll hear some of these terms used when people are talking about ranking individuals over time. But the take-home point is that in pure adrenal myeloneuropathy, it's a slowly progressive condition. So over 15 to 20 years, when we looked at this sort of retrospectively, most required some significant assistance to walk after individuals had come to the attention. This was both men and women, although women progress a little bit more slowly, and some of the individuals will require a wheelchair. So just touching on this, because I don't have enough time to go through it in depth, we do have therapies for adrenal leukodystrophy and adrenal myeloneuropathy. Adrenal hormone replacement is for the Addison's disease or the primary adrenal insufficiency. We have symptomatic therapies, which are a talk in and of themselves. And so just because this is a progressive condition and people go, there's no cure, does not mean that we don't have things that we can use in our armamentarium. There's been a lot of focus in the past couple of years on antioxidant therapies, predominantly by the group in Spain, led by Dr. Pujol. And the reason for that is that she's hypothesized that, and that's in the cartoon here, that there's reactive oxygen species and this affects mitochondrial function. And maybe if we downplay these oxidative stress markers, we will see improvement, and that's an ongoing research. In addition, there's this therapy we refer to as hematopoietic stem cells or gene therapy. And that stems from the fact that some of these individuals with adrenal myeloneuropathy will develop cerebral disease. Unfortunately, it seems to have the same restrictions that we see when we try to treat boys with cerebral disease. It has to be early cerebral disease. And we are still working on, and I think it's going to be addressed in some of the sessions, what the criteria should be for doing bone marrow transplant in early cerebral disease and adrenal myeloneuropathy. And with that, I think that's my last slide. Yes, for those of you who have missed it, it is 2021 and the year of the cicada here in Maryland. With that, I will pass this on to Dr. Fatemi.
All right, thanks, Jared. Trying to figure out how to connect myself with cicadas, but they're almost gone in our neighborhood. So I'm gonna continue. I don't see anything in the chat, so maybe we just keep going. Yeah, so I'm gonna move, just basically take it a little further and talk a little more about, so Dr. Raymond gave you a quick overview of what the different therapies are kind of used right now, but then I wanted to pick up the image that he showed earlier and elaborate a little on it to point out the sort of different therapeutic strategies that are now being considered and are actually being developed by several companies. And you're going to hear some of these companies later today presenting their individual research and development plans briefly. But again, this is sort of an image. Does everybody see my my slide?
Yes.
Great. So in the center, you see again, this is the peroxisome. These are those little organelles in cellular cells that break down the very long chain fatty acids, so C24, C26, and so on. And those are brought in through the ALD protein, like Dr. Raymond showed. And this is the protein that's missing because of the gene mutation in ALD. And so as a consequence, you get this elevation of these very long chain fatty acids. And there may be some other downstream effects that we don't know of directly related to the gene mutation, but at least what we do know is that these very long chain fatty acids affect our energy machinery inside our cells called mitochondria. Consequently, we get oxidative damage, like you just heard. So oxidative stress is when the mitochondria don't function well. It causes some disruptions in the cell membrane that may affect the way how cells respond, especially the endothelial cells, like Dr. Eichler's group has shown, and the inflammatory cells. And then there are some other effects, like Dr. Kemp, who's talking, I think, later today, has looked into other pathways that have been identifying recently being involved. This includes the so-called endoplasmatic reticulum stress. So one of the ways you can modulate that is by turning on something called AMPK that seems to be low in ALD that would block that stress. And then Dr. Pujol has also shown that something called the autophagy pathway seems to be involved. So as a consequence of all these, you can get sort of the dysfunction in ALD. One of the therapeutic strategies is to target oxidative stress. One of the therapeutic strategies is to increase this AMPK. One of the strategies is to turn on something that I pointed out here as red. So while ALD protein is not functioning in ALD, there is another gene called ABCD2. And ABCD2 is very much similar to ABCD1. And so what it can do is basically the same thing. It can bring the fatty acids into the peroxisomes. And so the ABCD2, however, in most cells that are relevant in ALD, is almost shut down. And there are many ways how you can try to figure out how to increase its function. So Dr. Kemp had done this many years ago with a drug called phenylbutyrate. And there is a whole group of medications now called thyroid agonists and other things that can increase your ABCD2 function to sort of find an alternative way to bring down the very long chain fatty acids. So, this is all great, but, when we want to do a clinical trial in a rare disease and we're going to focus on the AMN aspect, like we just heard, there are several challenges. So what is wrong in AMN? Again, Dr. Raymond elaborated on that. I'm just going to point them out again. So it's a slowly progressive disorder of gait, basically. It's affecting the sensation problems in the peripheral nerves, resulting in tingling, burning, numbness, pain. It causes weakness and spasticity, like you just heard. There's another aspect of the disease that is being increasingly more recognized, which is called dysautonomia, which is the nerves that go to the blood vessels. And so if they are not working, our blood pressure management is off and people can become orthostatic, meaning they develop dizziness, they can have positional fatigue, the feet can turn blue, or the feet can feel quite cold. And this is something we're starting to recognize more and more in this population that is potentially symptomatically treatable. Then there is bladder dysfunction, bowel dysfunction, major components of the disease. Dr. Eichler recently, his group really identified this being a big issue, especially the bladder dysfunction. In males, there's erectile dysfunction. And then, I'm not going to go into the adrenal dysfunctions as you already talked about it. So when we take these variables and say, okay, can we use these things that are off as our measures of outcome when we want to do a therapy? How would that be done? So the biggest problem right now is that we have all these different potential therapeutic strategies and targets and even drugs that we could test. But when you want to test something in a rare disease, the biggest challenge is you need to understand if it's actually working or not. And so, in order to know if it's working or not, you first need to know what is the rate of disease progression in the disease without any treatment, what we call natural history. And so we know it's slow and it's very variable. So that's challenging, because if you just look at somebody's neurologic exam, it may take many, many years sometimes to notice something that's significantly worse, which may be good for the patient, but it's difficult for the clinical trial to assess if your drug is working. And there is really no blood test right now or any sort of biomarker test or whatever specimen that I could take and predict how somebody's going to look like. So these are the two big weaknesses that we have. We don't have a good way to predict disease progression, and we don't have a good way to objectively evaluate if the therapy is working. So I'm going to talk about how we can do this now in the next few minutes. So what is an endpoint in a trial? In a trial, so this is defined by the FDA. If you do a clinical trial, you have to have an endpoint, and there are primary and secondary endpoints. The primary endpoint that FDA defines as something that's directly and meaningfully measuring what's wrong with the patient, the way they feel, the way they function, and the way whether they survive or not in a fatal disease. And so this is really key, because some of the things that the FDA has recognized in a neurologic disease as a primary endpoint is a walk test. There's a standard walk test that has been done in many clinical studies in other neurologic diseases called a 6-minute walk test. And many of you have had this test where you basically come to the clinic and we make you walk. And then you can see, does somebody's walk test get worse over time? And so this actually, we did a study. This was a study done by Dr. Raymond and Dr. Moshe himself back in the mid-2000s as part of a clinical trial with Lorenz Zoil, where we were assessing patients' walking speed and seeing how far can they walk. So on the right side, you see the 6-minute walk test distance in meters in the normal population. And so the average range is somewhere around 575 meters. But it's highly age dependent. As you see, as you get older, it declines. So it makes it difficult to analyze it because we don't have enough patients to stratify them for every age group. Secondly, the problem is if you are using a cane versus you're using a walker versus you're just walking without anything or with braces, all of this will affect your gait. And so analyzing this data is difficult. And so while in the males, we saw that there was a decline, a slow decline in their walking distance over 2 years, in women, it was kind of unchanged. And this is still unpublished data, actually, that we're trying to get out right now. But what you do notice that there was a small decline in walking speed, but it's not that dramatic. And so it makes it kind of difficult to use this as our single outcome measure in a clinical trial. So we've been looking for other outcome measures that would be helpful. And so because gait is a major issue, it makes a lot of sense to focus on gait analysis. And so there is a group of investigators now for over a decade that have been really focusing on trying to identify these outcome measures. So that's called a motion analysis laboratory. These labs exist in most academic centers. We have one at Kennedy Krieger, and there's of course other places as well, including Mass General and so on. And so what these investigators are really looking at is how does somebody walk, and you can quite quantitatively do that. And there's lots of machine learning tools these days that can take you put a person here, you put some electrodes on them, you have them walk on a treadmill, and then you can visualize it graphically, and then you can take that data and do a bunch of really sophisticated analysis looking at lots and lots of different variables that you can use as you're walking. And so when you do that, you get not just the walking speed, but you can get many different variables. How much do you bend your knee? How much do you bend your ankle? What is the distance between your two ankles? How much do you have step variability? And so you can look at all of these variables and try to see, do you find something that's meaningful? And so that's one way to analyze it. The other way you can do is, we know that, Canada, okay. We know that there is weakness. We know that there is muscle weakness in some major muscle groups in our legs, in the hip extensors and in the hip flexors. And so one of the things that you can do is you can try to quantitate measuring. So you have something called a dynamometer. And so you put that here and you ask the patient, pull their leg while you're pulling down, and then you can see how much force can they put on. So that's a much more quantitative way to measure strength than when I do it in the clinic as a neurologic exam, but it's basically just like a fist fight between me and the patient. And so here again, we see men were expected stronger than women, and there was a decline. But again, as you see, it's a relatively small level of decline. However, it was significantly worse in both groups, which is interesting. So it does get worse almost at the same rate between men and women over 2 years. So this might be a good measure, but again, we need to demonstrate first that this is a meaningful measure from an FDA perspective. Does the decline in hip flexion strength really matter? And so that's something that we are still trying to show. The other test that we like a lot, but the FDA hasn't still agreed on, is a test called the balance test or posterography or sway test. And so this is basically a test where you stand on the force plate, and this is Dr. Zakowski who basically did this in AMN cohorts. And then you can measure somebody standing with their eyes open, feet apart, eyes open, feet together, eyes open, eyes closed, feet apart, and then eyes closed, feet together. Now, eyes closed and feet together is a pretty tough thing. So even for control people, when you measure how much they sway, you see that they have a little, so if they're standing right in the middle, they sway a little bit from side to side, so you can measure that. In AMN, we see that there's a significant amount of sway. So that is basically a reflection of how much imbalance you have. And we see that this thing gets actually relatively significantly worse especially when you have your eyes closed. So eyes closed, feet apart, you see here that there's a significant difference. Interestingly, that's getting, again, worse, both in men and women. The higher, the worse it is, the more you sway. So as expected, men are more severely affected and they sway more. But both of them are really getting worse over time, over the same time period in 2 years. So we think this is a good outcome measure, but we need to convince the FDA that it's meaningful, meaning we have to correlate it with some other tests that show that it's important actually to the patient when they sway more. And we have tried to do that. So there is a neurological scale called the EDSS. I think Dr. Raymond briefly mentioned that. So the higher that score, the worse it is in terms of your clinical impairment. And we see that there is a correlation between your sway amplitude. So the higher your sway amplitude, the higher is also your EDSS. So, but that hasn't been sufficient so far to convince the regulators. So more recently, we recognize, well, this is all great, but it's going to be hard to have people come always to like 2 or 3 hospitals in the world to assess that. So how do we do that at their patients' homes? Is there a way to do it? And we have a junior faculty member, Dr. Smith-Fine, who's a pediatric neurologist who has really harnessed this technology called Opals. And so this is basically more or less like a Fitbit. And you have 3 of them. You put one on your belly and 2 on your feet. And we ship the patient the system along with the sensor and the laptop to their homes. And we can set it up in their homes. And they basically do a phone interview. And we have them walk at home. And so we can get the same measures in terms of sway and walking speed essentially at home using this technology. We think we can, but we're still in the validation process. So we actually have a grant together with Dr. Eichler and Dr. Vanderweer, where we're trying to do this study, and we are currently enrolling patients to have them assessed first in person and then have them assessed at home to see if this is as good as when you do it in person. If it is, that would be great, because then we can potentially use home assessments as an outcome measure for disease progression. And so just want to finish up talking briefly about blood markers. So we call them biomarkers. So biomarkers by the FDA are defined as a defined characteristic that measures what is normal in a biologic process and what is abnormal in the biologic process, or it can measure the response to some intervention. So there are different types of biomarkers. You can use a biomarker like very long chain fatty acid levels. That's a biomarker that shows that you have a disease. It's a diagnostic biomarker. And it may be to some level good for monitoring the response to your therapy, although we know that plasma very long chain fatty acids don't correlate with the disease severity. So we've been looking for many years now, many groups across the world have been looking for the ultimate predictor. Is there a marker that we can do in your blood and then say, okay, you're going to look like this in 5 years based on this blood value? And that's still the big open question. So there has been a lot of focus recently on something called neurofilament light chain, NFL, nothing to do with football, although it's elevated in football players actually that have head injury. And so this is really something that a study that Dr. England did recently and published recently. I don't know if he's going to talk about it, but basically it's something we can measure in blood very easily. It correlates quite well cross-sectionally with the impairment of a patient. But when he monitored it over 2 years, it didn't necessarily correlate with the severity of the disease, or wasn't really good in predicting disease progression in the AMN cohort. Now, in the ALD childhood cerebral, there is some new data that this may be highly predictive, and I think some of the speakers might talk about it again a little bit later. So we have taken a more sort of agnostic approach called omics. Omics means like, genomics, proteomics. So when you just don't know what you're doing and you just go for a fishing experiment, essentially. So this technology is possible now because we can basically look at thousands of different blood markers and say, hey, is there anything that is correlating with anything there? And so this is a collaboration with a group at the Henry Ford Health System in Detroit, where we've been basically sending them patient samples. And so if you sort of look at control people, mild AMN, and then the more moderate and severe AMN, we can try to identify these clusters of metabolomics. So these are clusters of people that fall under different groups showing different blood sample results, suggesting that we may be able to identify people's disease severity based on their blood signature and signature of these thousands of variables that we're measuring. And so this is really encouraging, but it's a lot of data and it's difficult to analyze it. And it's highly dependent on your sample size, because we have done this now in the pilot study. We need to do this in a more prospective cohort. And so then it becomes really complicated because you have lots of data and you have to analyze that big data set. So we've been working with a group of computer engineers to use machine learning tools to really take these big data sets, the clinical data and imaging data and all these biomarker data, and try to see if we can come up with an algorithm that is computer generated that tells us how the patient is going to do. So again, this is sort of something that my postdoc Bella Turk has been working on several years now. So the idea is that we would take a neurological exam, this wearable technology stuff, the gait measures and all that, the imaging data, and then the laboratory data, the biomarker data, put it all into this big AI panel. And then this machine learning tool, what it ideally would do is identify these different clusters. And so one cluster would be patients who will progress. One cluster will be patients who will develop cerebral ALD, and so on. So we're still in the midst of this. We don't have any data yet, but this is, again, part of the way to try to analyze sort of these more modern data sets. One thing that I didn't talk about at all is, like, one of the therapeutic strategies that can be used is replace the gene altogether, and that's called gene therapy. And Dr. Eichler is going to pick up on this moving forward. So I see a couple of questions. I'm wondering whether, Florian, do you want to talk first and then we address the questions, or?
Sure. Yeah, maybe I'll be quick.
Okay.
Yeah, thanks, Jerry and Ali. This was beautifully set up and nice to see all these new technologies, wearable devices, and more sophisticated understanding of outcome measures being done, because I think this is exactly what's needed as we are trying to move meaningful treatments and trials forward for patients. What I'm going to do is give just a brief overview of different gene therapy approaches. Here are my disclosures. So families should understand that when we talk about gene therapy, we're not talking about just one thing, but really different kinds of ways to correct the disease-causing gene. And this might be, on the one hand, an approach that entails direct delivery into a target organ, whether it's the liver or it's a certain compartment of the brain or spinal cord. Usually that employs something we call an adeno-associated virus. These are smaller viruses that can very effectively deliver to the nervous system. And that's in contrast to ex vivo gene therapy, which is a modality that requires you harvesting cells from the patient and then in a dish transfecting those cells, usually with a larger virus called a lentivirus. And then those cells are delivered back to the patient. And in the field of ALD and the nervous system overall, we are really thinking about these two delivery approaches to the nervous system, and I'll outline how this is playing out in ALD. Just to mention again the in vivo approach, which is direct delivery that can go into the brain or into that intrathecal space that you access when you get a lumbar puncture. And then in different diseases, there are vulnerable areas that targeting may be helpful to. In certain diseases, there's an easier ability of the protein or enzyme to cross from cell to cell. What's quite unique about ex vivo gene therapy is that this works very well for hematopoietic stem cells, meaning bone marrow cells that are able to produce bone marrow cells over time. So you're targeting here a stem cell in the bone marrow that then provides a lifelong source for corrected protein. And this is the strategy that is being used for cerebral ALD. Why does that work for brain disease? And that's been a question for many years and decades of neurologists. And we think that is because there's a certain type of bone marrow cell that can go from bone marrow to blood and from blood to brain. Those cells are called microglia. We're actually learning that there are other cells that can be repopulated in the brain, whether those are endothelial cells or other cells that surround vessels, and it's an active area of research. So just to highlight here the trial that was conducted in children with cerebral ALD and show you how gene therapy is being performed. When there is a lesion in the brain of boys with cerebral ALD and there's evidence of contrast enhancement, then we mobilize their bone marrow cells, harvest them, and select out a certain compartment of these cells called the CD34 cells. They're transduced with this viral vector I mentioned before, carrying a healthy copy of ABCD1. The corrected cells are then delivered back to the boys after a brief amount of immune suppression. And we did two different trials, one using busulfan and cyclophosphamide in ALD 102, and another one busulfan and fludarabine in ALD 104. And then we followed these boys for a 2-year period. This is really identical to what happens in a conventional bone marrow transplantation, with the exception that these are cells from the boys themselves. So I think this is an important difference that has prevented engraftment problems in graft versus host disease. Just to highlight the numbers here, that we have treated more than 50 boys across the world, and the trial has completed in both Europe and the US, and is going for filing. Please note that these are all boys treated in the early stages of disease. So they had an MRI score of an average of 2. This is an early lesion that is usually not extending beyond 1 or 2 anatomic areas of the brain. And they were all either early symptomatic or pre-symptomatic. So what are the outcomes? We use something called the neurologic function score that was developed by Jerry Raymond. And the higher the score, the more you are impaired. And you can see here that the majority of boys stabilized very quickly. There was one boy who was progressing at the time of enrollment, sadly succumbed to disease progression. There were 2 other boys who dropped out to undergo a bone marrow transplantation, but the large majority of the boys did very well and stabilized over time. What does the MRI look like? Here we use a scale called the LESS score. The higher the numbers, the more extensive the lesion. And again, you can see that about half the boys stabilize with their lesion growth immediately. The other half, about between month 12 and 24, tend to stabilize in their lesion growth. And just here an example of how this stabilization occurs in one boy who has the classic lesion in the corpus callosum, very different than when you would be untreated, where usually the lesion extends outward into the subcortical U fibers. Contrast enhancement goes away. Again, very different from what you see in the untreated condition, where a garland of contrast arises. Now, there have been questions around occasionally some faint enhancement rising and flickering on and off. So we decided we were going to quantitate that with and measure this with more advanced MRI measures. This is called perfusion imaging, looking really at the cerebral perfusion in the brain, and also able to really at a capillary level, small vessels that can be analyzed, as well as the leaking from those capillaries into the brain tissue. And what we invariably see is that after gene therapy, both the leakage improves as well as the heterogeneity of the flow, meaning that the flow pattern here is normalized. So I think this is promising. Does some of this take longer than with a conventional bone marrow transplantation? Possibly, but it might also come at the advantage of having no graft versus host disease and no graft failures. So at the time I presented this in 2020, it was 45 boys. We have now more than 51 boys treated, and the vast majority are alive and free of major functional disabilities. There are side effects due to myeloablation, and we had one case of transverse myelitis of unknown etiology. So I mentioned the promising efficacy and reassuring safety profile, but we have worries that the spinal cord is not appropriately treated because we have seen AMN emerge after bone marrow transplantation. So we've been thinking about a separate approach for AMN, and this uses an approach that was used for spinal muscular atrophy. Why are we doing this? Because the lower motor neuron is in close vicinity to the structures that you heard about from Dr. Raymond, dorsal columns and corticospinal tracts that are critical to AMN. And just to highlight, we get this into the right cell types, and we're able to lower very long chain fatty acids. In addition, also in a mouse model of the disease, we further optimize this by developing an intrathecal pump that can more effectively get to the spinal cord compared to conventional transplant. And we've been able to show that we get this into the right cell types when we deliver ABCD1, both into astrocytes and neurons, and we can lower very long chain fatty acids. Does it change behavior? When we deliver this into the ventricles of the mice that are deficient in ABCD1, we notice that the characteristic hind limb clasping we see emerge around 15 months is improved, not only after early delivery at 6 months, but as late as 12 months of age. And we've been very curious about why that is occurring. And we think it might be because we're delivering to deep brain structures that in the wild type animal, at least, have very high levels of ABCD1. So this is challenging some of our notions of AMN, and we're pursuing this further. Just briefly to highlight that the history of gene therapy has made tremendous progress over the past few decades. We've seen first in vivo applications of AAV in cystic fibrosis and also retroviral vectors in immune deficiency cell disorders that have now advanced to effective treatments for neurologic disorders. SMA has tremendously benefited over the past few years. And so we're hoping that this benefit will come to ALD as well. However, there are toxicities that we need to consider. As I mentioned before, for ex vivo lentiviral gene therapy, myeloablation-related events occurred just like in a conventional bone marrow transplantation, nausea, vomiting, fevers. We continue to monitor for insertional mutagenesis. We know that in retroviral gene therapy trials, not lentiviral gene therapy trials, there has been leukemia, and this is something we're watching closely. So far, we've not seen any oncogenesis. In AAV-mediated gene therapy, there can be inflammatory reactions in the liver. There can be an impact upon certain structures of the nervous system called the dorsal root ganglia. And there has been some preclinical data suggesting that in mice there can be cardiac toxicity So far, we have not seen that in humans. What I think is promising is to recognize that immune modulation and immune suppression can make a big difference when employing AAV-mediated gene therapy. And this is a study published recently in New England Journal of 2 patients treated with AAV for ALS. And it was found that the one patient who did not receive immune modulation had a neuropathic pain syndrome and downhill course, whereas the other person who received immune suppression was able to be stabilized. So I think this is quite promising and points to the fact that we have now some reassuring safety and efficacy data in the first gene therapy trial for cerebral ALD. And so for LENTD, they offer an alternative, particularly for those boys who are lacking a matched sibling donor. But you have to treat early and before the lesion is too extensive. For AMN, you would probably use different approaches, such as new AAV capsids that can deliver to the brain well. So it's important to understand target structures and target cells well. So I think for families, what's most important to understand is that we have achieved a lot in the field of ex vivo gene therapy, but we're not quite at goal yet. EMA has recommended approval of an ex vivo gene therapy, for cerebral ALD, and submission of BLA with FDA is on track, expected mid-2021. There is clearly a hiatus period right now where we are thinking and working on different expanded access options for children, but we're hoping this will be managed in close collaboration with sponsors and different centers. Important that there's no clinical trial right now for in vivo AMN gene therapy, although clinical development is underway. So I just wanted to thank everybody who contributed here, knowing that it takes a village, and glad to take any questions. Ali or Jerry.
All right, there are a couple of questions that have been submitted through chat, so I'll go ahead and read those off and let you guys decide amongst yourself who would be the best to answer. So from Luann, we have a question for Dr. Raymond and Dr. Fassimi. Does adrenal hormone replacement for Addison's prevent progression of ALD and or AMN? Has there been any research or even research in other diseases like MS, etc., that indicates that it does or does not?
Dr. Raymond, do you want to answer or do you want me to answer? Well, I think the answer is no. There's no effect on disease progression, and many years ago, even trials of high-dose steroids for preventing cerebral ALD were done in boys. So treating the adrenal disease does not stop progression of ALD.
I would second that. So there have been several trials. There's a couple of case reports out there that I think are just an error, that they say that they've treated aspects of adrenal myeloneuropathy, but the long-term outcomes have not been different. So there's no evidence of this.
Okay, second question is from Walt. Is there a connection between female carriers and high blood pressure?
No. There's no connection. High blood pressure is incredibly common in the population based upon our lifestyles, and so unfortunately, there's no connections between that and this condition.
Okay, and then we have one from Brad Bauman, which is, how do we sign up for the wearable How do we sign up for the wearable device for GAIT? Also, how do we take part in the Henry Ford project?
So so that's basically the wearable technology is part of a grant, which is a multi-center grant The idea is that you get first seen at a site and get enrolled on site for the study, and then the remote assessment will be done at your home. So if you are a patient at MGH here at Kennedy Krieger or at Stanford or in Amsterdam or any other of the sites that we call the GLIA sites, technically you can get enrolled into this study. If you're not currently a patient of any leukodystrophy center, you can reach out. I'll put an email address here. You can reach out to. But if you're a patient in any of the leukodystrophy centers, it's basically the easiest is to get enrolled through consenting to participate in research there. For the Henry Ford project, that's basically a blood draw. Right now, we are collecting samples only at Kennedy Krieger and then sending it there after we do the phenotyping. So after we describe the severity of the patient. So, so that would have to be a sample that has to be drawn here. We have to process the sample immediately to make sure that things don't get degraded. So, so that's not currently something where you can go and just ship us a blood sample. We have to process it. Do you have anything to add, Florian, or did I cover it correctly?
No, perfect. Yeah.
Okay, do we have any other questions for our speakers? You can either type them in the chat, or if you would prefer, you can unmute yourself and ask your question.
Jerry, I see there's one question about AMN, if you want to take that, or I can step in.
I'm trying to read it from here. I'm sorry.
Hold on. So it's from Luann. It says for any or all. So in AMN, is it the spinal column or far out, like foot, calf, etc., nerves that are demyelinating, or is it the brain nerves, or all?
So there is some evidence of peripheral nerve involvement. So if you look specifically for that, however, it's predominantly the spinal cord projections, I would say. And so quantifying the difference between the peripheral nerve and sort of the myelopathy can be difficult. And but I think it's predominantly the spinal cord leading the process here. And the bigger question, which I don't want to get overly involved in, is it an axon, which is the nerve fiber itself, or is it the myelin around it? And probably the answer is yes. You know, it seems to be predominantly an axonopathy to start with, but there's probably secondary myelin changes occurring also. If anyone wants to disagree with me, I can mute myself and let them talk.
Okay, well, if we don't have any other additional questions, I'm going to ask if Dr. Kohler and Dr. Van Haren, if you're prepared to begin your sessions a little bit early.
Yes, of course, surely.
All right, and then Dr. Fatimi, do you have any sort of intro for them? Or is Dr. Kohler good to go whenever he's ready?
I don't think Dr. Kohler needs an introduction.
Thank you.
He is one of the most renowned investigators in adrenoleukodystrophy in Germany. He relatively recently moved to the University of Leipzig, and he has mentored many of us. Go ahead, Wolfgang.
Okay, and we do have one more question that's come through before Dr. Kohler begins for the AMN panelists, which maybe Dr. Kohler can chime in as well. But Kelly asked, for someone who has AMN and Addison's, can you tell me where the best place for us to start the journey to be seen by one of you?
Maybe I'll just chime in and say, if you have Addison's, you should probably need an endocrinologist close to you. So, we as experts, we can certainly see and advise on the neurologic symptoms, but it's very important to have local care for adrenal insufficiency. If you have an Addisonian crisis, there has to be a local provider who can go to the emergency room or at least advise there. But either one of us, I think, can see you, Kennedy Krieger or Mass General.
If you contact us also, we can probably let you know who's like closest to you state-wise. So I put in the email address here and just reach out.
The email address for Kennedy Krieger is leukodystrophy@kennedykrieger.org. Dr. Eichler has put his email in the chat as well. It's feichler@partners.org. And if anyone watching this on YouTube wants those email addresses, please shoot us an email at office@ulf.org. Okay, thank you so much. Go ahead, Dr. Kohler.
So I hope you can see my screen.
Yes, we can.
Okay. So I'm very happy to talk about a new treatment option that's coming up, and we tested in a large multi-center clinical treatment study in patients with adrenal neuropathy. So you already heard something about this disease, so I don't want to be too much redundant, but I just want to emphasize that this is an inborn error of metabolism. So a substance called very long chain fatty acids are elevated in these patients, and also we have some problems with the adrenal glands and nervous system. So the characteristic of AMN is clearly a neurodegenerative, chronic, progressive, spastic paraparesis, is causing gait imbalance and ataxia and sensory disturbances, as well as pain and bladder and sexual dysfunction. But in addition, there is a lifetime risk for developing inflammatory brain involvement, which is usually correlated to a high mortality within 2 to 3 years. So this is a very dangerous situation. So how can we treat this ALD or AMN? Of course, we already heard something about symptomatic treatments for pain, spasticity, but also restless legs, bladder and bowel dysfunction, but also mood disturbances, and of course, adrenal dysfunction and sexual dysfunction. And a second point could be, this is always under discussion, but I'm personally very convinced that a metabolic disturbance, metabolic disease should be also treated with a metabolic treatment. So normalizing of very long chain fatty acids with diet and Lorenz's oil is one thing that is possible in the treatment concept of this disease. Once cerebral involvement occurs, we have already heard about the possibility of having hematopoietic stem cell transplantation, which is available for childhood and adulthood cerebral ALD, and the ex vivo gene therapy, which is currently only available for the children. So, but the question is, if there are specific medications addressing for example, the underlying disease cause. So there is nothing yet. So I was glad to report from a large randomized, double-blind, placebo-controlled, multinational, multi-center clinical trial using a drug called leriglitazone in adulthood male adrenal neuropathy patients. Leriglitazone is substance that is previously similar to a substance that is previously used in diabetes. And there are quite a lot of preclinical studies in animals, for example, showing that this drug has the potential to beneficial affect the pathogenic pathways in ALD and AMN. For example, the possibility to reduce metabolic oxidative stress, to restore energy depletion, which is caused by mitochondrial dysfunction in this disease, and to reduce brain inflammation, and possibly promote myelin repair. So there's good reason for trying this compound in patients with AMN. So it is, of course, my honor as a coordinating PI of this study to present data from on behalf of many sites in Europe and US, and the sponsor of this study, which is Minorix Therapeutics. Well, this study is the first successful placebo-controlled study in AMN, the most frequent adulthood phenotype in X-linked adrenoleukodystrophy. Controlled studies means that during a duration of 28-day screening phase, patients were randomly assigned to receive either the drug, which is lariglitazone, or placebo, and neither the study participants nor the investigators knew what they got during 96 weeks double-blind treatment periods. Afterwards, an open label treatment was offered and was accepted by 92% of the patients. So males between the age of 18 and 65 with genetically confirmed ALD participated in this study. Patients had to have a mild to moderate disability with EDSS scores less than 6, which roughly translates to ability to ambulate with an unilateral aid for about 100 meters. Patients had to be able to walk for 6 minutes and stand on a force plate with closed eyes and feet apart for 20 seconds or more. You already heard about these measures before from Dr. Fatemi. Patients with evidence of inflammatory lesions in the brain are seen in MRI imaging were excluded from the study. Also, additional exclusion, patients were excluded with cardiac problems, with diabetes or anemia. So change from baseline to baseline after 96 weeks in a 6-minute walking test was chosen as the primary endpoint for the study. It was a priori adjustment for change in walking aids and primary sensitivity analysis to account for changes in body weight. Based on the natural history data, was an expected decline at 96 weeks to be around 60 meters. The expected treatment effect was defined as reduced decline by 45 meters. There are quite a lot of secondary endpoints. For example, MRI severity score was used and body sway measures and balance measures that are key secondary endpoints. And in addition, multiple secondary endpoints, including multiple clinical endpoints, patient-related outcomes, and exploratory endpoints, for example, biomarkers or spinal cord imaging, was used for the evaluation in this study. Well, 116 patients were randomized. 96 subjects completed the study, and 85 patients entered the extension phase of the study, which is currently ongoing. 20 patients discontinued, with 9 patients withdrawing the consent. While the patient characteristics at baseline in the 2 study groups was similar but not equal, which is statistically meaningful, and which will be discussed in my talk a little bit later, a little bit more. And remarkably, patients in the placebo group had a longer disease duration at baseline, with clear impact on 6-minute walking tests, body sway, and score, which is used for to quantify the myelopathy in the patients. Well, now coming to the results, no difference was observed between treatment groups regarding the primary endpoint, which was the 6-minute walking test, when the entire study population was considered. So the primary endpoint is not met. With pre-specified adjustment for body weight changes, patients in the active arm showed almost no decline over the 2 years of the study in the 6-minute walking test. However, this difference versus placebo is too small to conclude on treatment effects in this full in the whole group of the investigated patients. However, a closer look at the data detects that the treatment effect appears to be dependent on age and disease duration. It appears to be more marked in younger patients with shorter disease duration, suggesting a higher disease progression in the earlier stages of the disease. In this per protocol population, lariclitazone treated patients, which are the blue columns here, show over time no further progression independent of the cutoff of the disease duration, while patients in the placebo group, which are the gray columns, show decline when shorter duration of the disease. As you can see here, there's a big difference. On patients with 10 or less years of myelopathy, these data reach statistical significance. In the delta active versus placebo is in this case more than 30 meters over these 2 years, so which is clinically meaningful in our eyes. This treatment effect also holds true looking at the whole study group, early disease stages versus late stages, with meaningful clinical benefits versus placebo in patients with myelopathic syndromes onset less than 10 years ago, as you can see here and here, which is a big difference versus the whole group. Well, this finding also correlates to an upward change in walking aids, which is more frequent in the placebo arm, suggesting a beneficial lariclitazone effect on ambulation. And here are some examples of these patients who are deteriorated and using, for example, in this placebo patients here, you see there are 3 patients who are walking independently at baseline, and they need to have some walking aids or even walkers later on. So there are more patients deteriorating with their ambulation in the placebo group versus in the active treated group. Well, it was already mentioned that balance and body sway metrics are emerging as a more attractive, objective, sensitive, and clinically relevant endpoint in terms of functional impairment and quality of life in AMN patients. And the loss of balance and increased body sway is associated with spinal cord dorsal column degeneration, a pathological finding that is present nearly in all AMN patients. So data from these sway measures and balance measures summarized in this table show that patients on liraglutide reached statistically significant differences for total and mediolateral endpoints with eyes closed, feet together condition, and anterior posterior endpoint with open eyes, feet apart paradigm, as well as numeric but not significant differences in all other conditions. Well, looking at the cerebral lesion progression and based on the prior natural history data, approximately 60 or more than 60% of AMN patients are at risk to develop cerebral inflammation and demyelination within 10 to 15 years, with mean survival rates of 3 to 5 years, highlighting the clinical relevance and significance of cerebral lesion progression. In the study, we looked at MRI changes in a 2-level procedure. At site level, we recognized 6 cases of progressive cerebral ALD. There was also a central reading detected 5 further cases with progression of cerebral ALD on new occurring gadolinium enhancing cerebral inflammation lesions. So cerebral lesion progression was found significantly less frequent in patients on the active arm of the study, while there was 8 patients, which is about 20% or 25%, with new or growing cerebral lesions in the placebo group. None of the liraglutide treated patients developed post-baseline incidence of new gadolinium in positive lesions. And this table summarizes primary and secondary endpoints of the study. There were significant differences between most of sway measures, as I mentioned, and disease-specific brain MRI disease burden as measured by the MRI score. And post hoc analysis also showed significant differences in changing in walking aids and more significant differences in the primary endpoint 6-minute walking test in patients with shorter reported disease duration. Well, overall treatment is well tolerated. Also, treatment-related adverse events are elevated in the active arm. There was one severe adverse effect reported in a patient with elevated liver enzymes, which was genetically later on confirmed as a pre-existing liver disease. And not related to the treatment, to the drug. And there we had one grade 3, which is very severe treatment emerging adverse events due to an anaphylactic shock caused by a food allergy, which is also not related to the medication. Most of the adverse effects could be ameliorated or even solved by dose adjustments or temporary drug suspension. The most common side effects was edema and weight gain in 64 and 70% respectively of patients on the active arm and 18 and 23% in placebo. And also increased lacrimation was observed very frequently. While edema responded well to dose adjustments or diuretics, and clinical progression of the ALD was only reported in placebo arm in 6 patients. Well, in summary, this is the first and only controlled clinical trial in adrenal neuropathy. Again, I wish to thank all participating patients and cooperating multinational study centers. Data from preclinical studies suggest a strong rationale for this clinical trial, since the drug is effectively targeting multiple pathogenetic relevant pathways in ALD. Well, unfortunately, the primary analysis in 6-minute walking test did not show statistically superiority for leriglitazone. Both groups showed modest reductions in walking distance within the placebo group, was less than expected from previous natural history data. However, post hoc analysis revealed greater effects in 6-minute walking test in early stage patients with less than 10 years myelopathy symptoms. This finding is clinically plausible and supported by natural history data. And the difference in the 6-minute walking test change at week 96 are clinically meaningful improvements in stabilization of walking. We also detected some favorable trends in EDSS ambulation in the overall population and highly significant differences in body sway and balance measures. Positive treatment effects are especially seen in this body sway and balance with clinical meaningful impact in day-to-day function of patients, enabling them to independently move in dim light, uneven surfaces, or washing themselves or using a toilet. We saw also significant reduction in the incidence of cerebral lesion progression, leading to cerebral ALD. And such results were aligned across radiological, clinical, and biomarker-based observations, which are not mentioned in this talk. MRI results clearly favor active treatment, as only patients in placebo arm develop clinical progressive cerebral ALD. Well, entirety of efficacy data consistently support that leriglitazone provided clinical relevant benefits on the main myelopathy-related endpoints, namely ambulation, balance, and overall disability. Similarly, leriglitazone showed important effects on the life-threatening progression of cerebral lesions. And in case of primary endpoint, 6-minute walking test, impact of years since onset of myelopathy symptoms is particularly pronounced. And while endpoint was not met in the entire population, it showed clinically meaningful and statistically significant effects in early stage patients. So thank you very much for listening.
Before we pass it on to Dr. Van Heeren, there are a couple of questions in the chat. So Dr. Kohler, were NfLs measured?
Neurofilaments? Yes. We measured.
I think that's what it's asking. Yeah, NFL.
Yeah. Well, these were measured, and they are correlating with the drug effect. So patients with more severe involvement of brain, for example, getting the cerebral lesions during the study, in these patients we saw a dramatic elevation of NfLs. So this seems to be a good biomarker in relation to a disease activity. That's what we think in the moment.
All right, and the next question, this is from David. It says, I am just looking to be clear, the studies that Dr. Kohler is discussing specifies only ALD cerebral damage patients, or were AMN patients older at diagnosis with white matter leakage in the brain tissue the subjects?
Well, the subjects of this study were only AMN patients without contrast enhancing brain involvement. So patients with non-contrast enhancing lesions were also feasible for this study. But as soon as there's some gadolinium enhancing lesion, a patient was excluded from this study.
Okay, the next question is from Luann. For Dr. Wolfgang, did the patients in the study get any decrease in pain, weakness, or spasticity during their use of the drug?
Well, this is a very good question, but we measured these not specifically, only indirectly. So we had some patient-related outcomes, quite a lot. I did not present all data. There's so much data, so I would need a couple of hours to tell about this. But there are especially patient-related outcomes which show that there's also some beneficial effect of the drug-treated patient versus the placebo patients, which is for many of these quality of life measures and global impression measures, both from the patients and from the treating physicians, are significantly different in the treated versus the placebo patients.
Okay, next question is from Burl. Is there any pursuit of FDA approval for larogetilazone in the US?
Well, I would I cannot answer these questions really at the moment. So maybe I could pass these questions to the representative of the company, which is speaking later on in this session. So there's a representative from Menorix, maybe he can give you an answer on this. The only thing that I know is that there are currently is the intention of the company to talk to authorities both in the US and the EU to have some negotiations to have this drug approved further on. So, but these are this is work in progress. So maybe you can save this question a little bit later. You may get an answer from the company itself.
Okay, so Menorix will be speaking at 12 p.m. Central Time. So that's in about an hour and a half is when that session will be. So just so everyone knows. And we do have one more question in the chat so far. If there are any additional questions for Dr. Kohler, please either put them in the chat or once he's done answering this question, feel free to unmute yourself and ask him live. But the question we have from Bernard is, could the drug be used preventatively for asymptomatic adult patients who have the mutation? Is this drug currently being used for any other condition? And could it benefit cerebral ALD patients? Any anecdotal evidence?
Well, these are very important questions. We did not look at asymptomatic patients. So the patients in this study already had symptoms. So it's most likely, I think that it's not appropriate to use it in a pre-symptomatic situation. If the drug is really helpful in patients who had already some cerebral involvement, is a very important question, which is currently addressed in some further studies, but I cannot give you any results on these yet.
Okay, is there anyone that would like to ask a question by unmuting themselves? Otherwise, we will have Dr. Van Haren present his presentation. Okay, if there are any other additional questions, feel free to throw them in the chat. We are running a little bit early, so we do have time. But Dr. Van Haren, if you want to pull up your presentation And then whenever you're ready, you can begin.
Thank you.
Great. Thanks, Dr. Kohler. Just want to point out how important and exciting the trial that Dr. Kohler presented is. And it's the first, I think, of, we hope, several trials that will be done in the next several years in AMN. And yeah, I'm excited to see more. So I'm going to present a study that we had done in the US. It was a pilot study of vitamin D supplementation ALD boys. So this is not in adults, it was targeted toward children. I'll say the premise for the study, how we designed it, and some of the outcomes and some of the next steps. So the study, it was funded by the NIH primarily. We also had funding from several individual donors, as well as from the Lucile Packard Foundation for some trial analysis. So I do have some relevant or some related funding in ALD that was not applied in this setting, but want to mention also we've got some wonderful collaborators here. This was really a large, it was a small trial, but trials require a lot of people, and there were a lot of wonderful collaborators here. The members of my lab shown on the left, and we had our main collaborators, which were Kennedy Krieger Institute, with Dr. Patimi, Dr. Barker, and Dr. Raymond, all involved in some capacity. So I want to give a quick shout out to our terrific ALD team at Stanford. We have an ALD and AMN team there. This is really, even though I led the trial, this really couldn't have been done without a large network of people supporting some of the infrastructure as well. So quick background, very brief on cerebral ALD. This is just a couple slides showing what an early ALD lesion looks like. So like, you know, the brain and life begins for ALD boys with normal, I'll just tell you a very normal appearing brain. And of a child who presented with renal deficiency, and some months later presented with signs of early lesion. And so this is what we are looking for when we're doing serial MRIs in boys. And this finding here is an indication that there is active brain inflammation. And this is often the time, or typically the time, where we will triage to bone marrow transplant. Now, hypothetically, this is not the same patient, but if we do not triage to bone marrow transplant, the lesions typically continue to grow, and they get larger and larger without treatment. And so this is what we're trying to prevent. Should also mention here that this early lesion is asymptomatic, and the lesions really don't become clearly symptomatic until they're maybe this size or a little bit smaller. And we have good treatments for stopping lesions once they start through bone marrow transplant. What we don't yet have are good prevention strategies. So preventing brain lesions from going from this, so no lesion to a lesion. And this has long been an interest in the field. We think it's achievable. We're looking for strategies to do so. So I run a neuroimmunology clinic at Stanford. And so my clinic practice involves seeing patients with neuroinflammatory disorders like MS. And we borrowed some of the ideas from multiple sclerosis. And multiple sclerosis is an autoimmune demyelinating disease that has many similarities to ALD and some differences. But in MS, we have scattered inflammatory brain lesions in the white matter. And in ALD, and these come and go. And in ALD, we have large aggressive inflammatory brain lesions, but nonetheless, we hypothesized that there may be some shared histology or some shared pathophysiology. And so we thought that perhaps borrowing from what is known about vitamin D and multiple sclerosis, where vitamin D levels have long been associated with MS risk disparity where latitude, so more central latitudes in the globe, near closer to the equator, have lower rates of MS. And also, this is depending on your vitamin D level when you have MS. So this is vitamin D level on the bottom here, and this is the number of relapses. This number here is the relapses per year. And the number of relapses per year tends to go down up to a level of about 40 nanograms per milliliter in the blood for MS patients. And so we sort of borrowed from this idea that, well, let's see if something similar might be true for ALD patients. And I think I took our slide out on some of the data, but we did identify, up there it is. So what we found were that blood levels in patients with cerebral ALD had lower vitamin D levels than those without cerebral ALD. And in collaboration with Dr. Bonkowski's lab in Utah, he also found a latitude gradient. So higher latitudes, meaning where there's a little bit less sunlight in some portions of the year, patients tended to have slightly higher risk of cerebral disease as well. Okay, so how might vitamin D be working in ALD? Well, the answer is we don't exactly know, but we, in the case of MS, vitamin, and more generally, vitamin D does have important properties involved in immune regulation. So it helps make the immune system more less aggressive and more tolerant, and this is generally beneficial. And this is generally it's presumed and I would say partially proven mechanism in MS. There are also some interesting avenues linking vitamin D to oxidative stress. So higher vitamin D levels lowering oxidative stress. Both our lab and other labs have produced data like this. And lipid metabolism may also be a mechanism. This is one that has some data supported, suggesting that higher vitamin D levels may associate with decreased saturated fatty acid production and perhaps improvement in beta oxidation. And then we're interested in some energy efficiency. So this is just basically mitochondrial function would be one simple way to think of it. So there are some suggestions that vitamin D might improve mitochondrial function. So we started a pilot study of vitamin D in ALD boys, and we were targeting 20 patients for enrollment. And the design was a 12-month exposure where we took measures at the baseline, the blood and the brain, and then we checked again at about 6 months, and then again at 12 months. And for many patients, we increased the dose over the course of the study, depending on their vitamin D level. And we completed analysis. And this study was done, started in October 2016, and we completed our last patient visit in June 2020. And it was done at Stanford and Kennedy Krieger. The goals of the study were to develop data for a larger trial to study about cerebral ALD prevention. So this study was not designed to understand whether vitamin D prevents cerebral ALD. To do that actually will require hundreds of patients to enroll, which is a pretty tall order. But in this study, we wanted to find a safe dose, to find a safe dose to use in future studies. And we sought to also identify vitamin D biomarkers that might be useful for understanding how vitamin D might be influencing ALD in a favorable way. So we sought to enroll males with the gene mutation who were between 1.5 years and 25 years of age and had no evidence of cerebral ALD that was active and had vitamin D levels less than 60. And we did have exclusion criteria around abnormalities in fatty acid absorption, and vitamin D absorption. And here was our enrollment timeline. We had a slow enrollment early on, but right around the time that newborn screening patients became eligible for our study in California, enrollment picked up really dramatically. And we have we recently completed, just kind of in the very beginning of the pandemic, was around the time we completed most of the study visits. And we were able to fit most of the study visits into the before the pandemic really hit. We initially signed all patients, regardless of weight, so whether they weighed 10 kilograms or or above. We signed them all to 2,000 units a day, and then depending on their vitamin D level at the mid-study point, we would increase to 4,000 units a day. For various reasons, we had to modify this dosing regimen. Some of these smaller patients proved to actually this relatively small dose proved to be too high a dose for some of the smaller patients in the lower weights. So their vitamin D levels became too high. And so we had to modify and weight stratify the dose. And this was eventually the dosing strategy we used, where smaller patients started at 1,000 IU, and then they escalated to 2,000 IU as needed. And something similar was applied for patients who had lower weights, where we escalated to 3,000 instead of 4,000 for patients in the middle. So in effect, we enrolled patients, the first 12 patients, to a fixed dosing regimen, and we enrolled our last 9 patients to a weight-based dosing regimen. Everyone completed all study visits, and in total, our median age was about 6.5 years, with a range of from about 1.5 years to 22 years. And we had a median weight of about of 20. And we had a reasonably diverse cross-section, but about half of the patients, a little more than half, had adrenal insufficiency at enrollment. And the median vitamin D level at enrollment was 29. So here's in total, patients started at a vitamin D level around 29, and they increased even at the 3-month mark to a vitamin D level close to 60. And they were generally maintained there. This was within our target range. So our target range was really between 40 and 80, and most of the patients stayed there through the study. If we look at the 2 different arms, so if this was our fixed dose, the blue line here, and these patients tended to run a little higher and than the patients on the weight-based dose. We had, when we look at what our primary outcomes, we're basically looking at who achieved their kind of our target level, so 40 to 80 nanograms per milliliter. At 6 months, 86% of patients were at target. At 12 months, we had fewer patients at target because some had gone over target. And I don't have the breakout here, but I'll say that some of the patients on the fixed dose went over target, and the patients on the weight-based dose tended to be slightly under target. And then if we look at adverse events here, we can see that patients who were over target are in this are highlighted by the red here. These are the patients on the fixed dose. So the fixed dose patients, these are small, generally smaller patients, younger children. Their level, vitamin D level tend to go over, and what we would do is, part of the study protocol, we would reduce the dose. There were no symptoms associated with this, but it was something that our protocol was addressing by adjusting the dose. We also checked urine calcium excretion levels, and those levels were also asymptomatic, but they tended to be elevated in patients on the fixed dose. And on the weight stratified protocol, again, which took into account patients who had a lower body weight, no laboratory adverse events were noted. In terms of predefined adverse events, we're looking at serum vitamin D levels, serum calcium levels, urine calcium levels, kidney stones, development of brain lesions, development of adrenal insufficiency, and then any hospitalizations related to vitamin D and hospitalizations that were unrelated. We had 4 patients who had vitamin D levels that were too high. They were all in the fixed dose arm. 3 patients had urine calcium levels that were high. Those were also all in the fixed dose arm. And then 1 patient developed adrenal insufficiency during the study period. And 1 patient was hospitalized for an asthma attack, which was considered unrelated to the study drug. In general, we had kind of a typical profile of adverse events reported during the study for our study age. So we had 10 participants with cough or cold or runny nose during the study period, 9 patients with GI symptoms, 7 patients who had developed fever or headache or subjective weakness. These were generally fairly typical group. So they were seemed to fit the idea that a more weight-based protocol might actually be better. I was unclear whether these which of these might actually be related to drug, but there did seem to be some suggestion that a weight-based regimen seemed to produce fewer adverse effects overall. So measuring glutathione was one of the targets we picked as a biomarker for our study. Glutathione is one of the key antioxidants in the blood and the brain, and this is known to be decreased in ALD. And it is low levels of glutathione can be associated with cell injury and certain forms of cell death. So normalizing antioxidant levels, particularly glutathione, is considered a reasonable target. It's unproven whether it can make a difference in ALD clinically, but this is one of the biomarkers we saw here. And our hypothesis was that vitamin D exposure would increase the glutathione levels in the blood and in the brain. And we collaborated with 2 labs at Stanford and at KKI to look at this. The Cowan lab used mass spectroscopy to look at glutathione levels in the blood. And the Spielman lab and Barker labs at Stanford and KKI used MR spectroscopy to look at brain glutathione levels. We found a non-significant trend. There was no statistical difference between the baseline and entry in whole blood over the course of the study period. We did see a significant increase in brain glutathione over the study period, and we saw this in 2 sites, both in the back of the brain where ALD lesions can form, and on the front of the brain where ALD lesions can form. And so this was visible at the 12-month study mark at both sites. I'll also add here that since we initiated this study, several randomized controlled trials with placebo arms have demonstrated vitamin D's role in increasing blood glutathione. So it does look like this is a viable kind of target biomarker for vitamin D. Our study was quite small and it was not placebo controlled, but it does look like the approximately 10 studies who have randomized placebo controlled studies who now looked at glutathione in randomized controlled vitamin D studies. I think it's 8 or 9 of them have shown a significant increase in glutathione. So it looks like it's a reasonable target. We just didn't quite hit our significance there. We were also interested in brain perfusion. So you can measure brain perfusion using MRI as well, and you can do it without any intervention using basically magnetic labeling of the blood or the protons in the neck. And so using a magnet during an MRI, you do a sequence where you apply a magnetic pulse to a very small part of the body in the same way you would the rest of the brain. it magnetically labels the blood, and as the blood flows through the brain, the magnet can also read where the blood is going, and it can produce these very nice images. And so it's mostly been used to study stroke lesions, and you can see this the dark blue here is where blood is not flowing in a patient who's had a stroke, and the red regions are where blood is flowing. And so this is where there's a deficit of blood flow. And Dr. Mussolino at Mass General Hospital does some really wonderful work looking at this very same phenomena in ALD patients, and has also found signs of low blood flow in ALD brain lesions. And so we hypothesized that vitamin D might also improve brain perfusion, and if it did, it might be a good preclinical biomarker to follow here. We found some interesting results at month 0, 6, and 12. This is basically an averaged image of the brain perfusion in all ALD boys, or I should say 18 of the 21 ALD boys in our study. And here we see that in the areas we were interested in, which is particularly the splenium was our primary area of interest, but also the frontal region, you can see that these areas are becoming a little more red, which means that blood flow is increasing to these regions. And over time, it looked like vitamin D levels were even correlating a bit with the cerebral perfusion. So we have the vitamin D level on the x-axis here, and then the blood flow in the y-axis. This is a small sample. It's a single arm, so causality is really hard to link. But we thought this is an interesting finding, and we're quite interested in carrying this forward in future studies. So in summary, we found that both dosing regimens achieved our target levels for vitamin D of between 40 and 80 in most patients. We did find that the fixed dose regimen pushed levels a little too high, and the weight-based regimen we had selected ran the levels a little lower than we intended for some of the patients who were larger. So we'll require we will use the data we have to modulate our dose selection a bit further. We also have a weight-based dosing we think was associated with fewer adverse events overall, which was a little bit surprising. Most of these adverse events were clearly related to drug, were just asymptomatic levels of vitamin D in the blood and then urine excretion in that of calcium. But even some of the cellular symptoms, like headaches and muscle aches, seem to be lower in our weight-based regimen, suggesting that there might be some subtle side effects in higher dose on. So I think in terms of understanding vitamin D's relationship with glutathione and brain perfusion, that really requires further study. It's not definitively linked here, but we think this is worth further investigation in the future. And our next steps are, first and foremost, to proceed to a phase 2 trial with age and weight-based dosing regimen for many more children. We're arranging this now. We're interested in a big, already quite a ways along, and some of our further analysis, a multi-omic analysis of the bioarchive samples we have from the study. And we're taking forward some vitamin D supplementation experiments in the ALD mouse model. So I want to thank our collaborators and our funders, and we can take some questions now.
Great, thank you so much, Dr. Van Haren. If there are any questions for Dr. Van Haren, feel free to type them in the chat or go ahead and unmute yourself and you can ask vocally as well. While we wait to see if anybody has any questions, they might be typing up. I'd like to ask Dr. Kemp, Dr. Lund, and Dr. Engelin to have their PowerPoints at least pulled up in the background and ready to screen share for their presentation that will start in the next few minutes. And okay, we do have one question from Bernard. It says, is the high dosage of 4,000 commonly used for any other conditions?
The doses, so doses that are commonly used in adults for vitamin D supplementation vary a little bit based on how low the vitamin D level might be at the outset. So that how your level of vitamin D at the beginning of supplementation is something your doctor will take into consideration when they start or when they recommend the dose. But generally for adults, 4,000 is a pretty safe and tolerable dose. For children, I would say for many children, it's too high. And in our experience, even doses of 2,000 were too high for some children. So in the very young age groups, vitamin D doses need to be sort of carefully considered. But in terms of which other conditions it's used for, well, now vitamin D is used for, I guess, supplemented for lots of reasons, including for general health. It hasn't been proven really effective in treating many disorders. The disorder really is most strongly linked to, other than vitamin D deficiency itself and rickets, is actually multiple sclerosis. That's where the best evidence exists. So that's where it's typically used. And doses of 4,000 are pretty commonly used in MS, sometimes even higher. I see a couple other questions. I can read them out too, Kelly. So I see a question from Luann asking about how much below normal vitamin D levels were in the boys at the beginning. The vitamin D levels at the beginning of the study ranged from fairly low, levels in the teens to normal levels in the low 40s at the beginning of the study. The average vitamin D level at the beginning of the study was 29. And then I see the last question here was, what sites will phase 2 trial be administered in what ages, and how does someone enroll? Thanks for asking. Our hope for the phase 2 trial is that people can enroll essentially from home, and they will be able to access the trial from wherever they are without excessive travel, and we'll be able to do remote monitoring and remote blood draws. We hope to have some specialized study sites where we can do some additional monitoring for MRI metrics, but more on that soon. How will things be registered? How will you be able to register for the study? We should have a pre-registration available for interest soon. If you can check our lab website, if you Google Van Haren Lab, we should have a survey up there within the next couple of weeks. Once we get things cleared with our IRB, you can register your interest there. The study been published. We're working on one final analysis for this study using a flow cytometry analysis. We're hoping that it looks like we have positive data for that study too. I didn't show that because this analysis isn't complete, but assuming we can sort out some of the signal to noise in that one, I think we'll be including that and be publishing soon. But we'll be submitting it for publication hopefully very shortly. The entire analysis is done except for that one piece. All right. I think if there are no other questions, we can maybe proceed with a little bit of extra time in our hands. What do you think, Kelly?
Yeah, absolutely. So our next session will be regarding ALD with the presenters, Dr. Mark Engelin, Dr. Stephen Kemp, and Dr. Troy Lund. I'll let one of them, whoever wants to volunteer to go first, feel free to bring up your presentation and proceed whenever you are ready.
Yeah, good afternoon. We democratically decided that I was going to be first. Okay, so this session, it's on cerebral ALD, but I will start off with an update on the newborn screening in the Netherlands. And I think you see my slides. So in 2000, so let me start with a few slides of history on newborn screening. Already in 2004, Hugo Moser at the National Advisory Committee for Newborn Screening in the US mentioned that, or argued that ALD qualifies for newborn screening because it would save lives. And the points he brought forward is that many of the boys before the age of 10 develop adrenal insufficiency, and it is often diagnosed late or too late. And there's of course a treatment for it. And but also 1 out of 3 boys will develop cerebral ALD before the age of 10. And if this is caught in time, then a treatment is available. But when boys have already neurological symptoms, this treatment is not available anymore. So newborn screening would allow monitoring these boys from birth on and initiate treatment in time. But mentioning that a disease qualified for newborn screening is one thing. You need to be able to screen this disease in newborns. And at that time, there was no biomarker available that would allow a rapid or high throughput screening for ALD. So a team was asked to do this, and at Kennedy Krieger Institute in the next years succeeded to identify C26 lysophosphatidyl-choline, or C26-lyso-PC, as a very good biomarker for ALD, demonstrating that all ALD patients have elevated levels compared to the controls here in green. And but then, okay, so a disease qualifying for newborn screening and a biomarker doesn't automatically initiate newborn screening. So a second important thing that we need to mention is the work done by Elisa Seeger in the state of New York. She made it happen that the state of New York approved Aiden's Law in 2013. And later that year, the state was the first on this planet to start screening for ALD. And in that case, we also have to mention Joe Orsini, who took this huge task on and made it happen. And now in 2020, 21, in the US, more than 60% of newborns are screened for ALD. And each year, many new states or additional states are starting ALD newborn screening. But the US is the only country that screens for ALD, except for this little country outside of the US. And then in 2013, the Dutch, we received notice that the Dutch Health Council had plans to expand newborn screening. And Mark Engelen and I, we took our chance and we nominated ALD. And what happened is that the Dutch Health Council, they used the US Recommended Uniform Screening Panel list, the RUSP list. And the version of that year, that was still the version of 2011, did not include ALD. But we knew that things were moving forward in the US. And with the help of Amber Salzman, Patrick Aubour, Dieter Martin, Charlie Peters, and Moser, and many others, we put our nomination on paper, and and we presented it to the advisory committee for the Dutch Health Council. And in April 2015, the Dutch Health Council published their new recommendations to the Minister of Health. And within a week, the Minister of Health took over the recommendation. And at that moment, the Netherlands had planned to add the newborn screening list with 14 additional diseases. So these are the diseases that are screened for in the Netherlands, or will be screened for, because here is a huge list, a large list. These are the 14 diseases that were going to be added, but you can't add 14 diseases at once. So this has to go in phases. And the last one that was added was MPS1, March of this year. And in January 1st, we started ALD screening. But you see that this is in a pilot, and I will explain why this is a pilot and not just nationwide. And for that, it's important to show you, well, a short summary of the guidelines that for newborn screening. That this is a short list of the larger guidelines recommendation from Wilson and Younger in 1968. And the first well, guideline is recommendation is that early diagnosis must directly benefit the neonate. And well, if you just look at this item, and that's actually what the Dutch Health Council did, is they said that screening for ALD is only useful for male newborns because the symptoms in women usually arise later and cannot be treated. And it's the boys that develop adrenal insufficiency and cerebral ALD. So therefore, the committee recommends to only screen male newborns for ALD in the newborn screening program. So in the Netherlands, it would be only boys screened for ALD, and in the US, it's boys and girls. And that is, well, that is a challenge because gender-specific screening had never been implemented for any disease in any newborn screening program worldwide. So we did not have any example. And that's one of the reasons that a pilot study was needed, because we had to set it up. And that pilot study is called the SCAN study. And this is its logo. And we started that 2 years ago. And this is the Netherlands. And we have 12 provinces. And when we think of ALD newborn or of newborn screening, the country can be divided in 5 regions. 5 newborn screening regions, and all these regions they have their own newborn screening lab. And the pilot is not nationwide. It covers, it includes 2 newborn screening regions. So this one in purple with 2 provinces, and the one in orange, and also 2 newborn screening labs. The pilot will last for at least 12 months. And we will screen at least 70,000 newborns with ALD. And the task that we have is to develop and test a boy-only algorithm. But that's a challenge because, as I said, there is no example that we can just use. So we have to come up with a strategy to do this. And it's not official, but I was told by one of the members from the Dutch Health Council that, yeah, they thought, well, it's mentioned on the card because here it says boy, girl. But we did a little study there in one of the newborn screening labs, and it turned out that for whatever reason, 2 to 4% of the cards is not filled out correctly or incomplete. I mean, anything can happen while taking the heel prick. So, but it turns out that in some cases, this box is not marked. And also sometimes the gender of the newborn is unclear at birth. So we cannot go on by the information provided on the cards. So the challenge that we had is to design, develop, and validate a screening algorithm that includes a test or a tier that identifies males using only the dried blood spots, so not the information anywhere else. So we had to go by the blood that was available. And also, we should not identify unwanted findings or untreatable diseases like Klinefelter syndrome, Turner syndrome, or some of the other diseases that you can pick up with C26 lyso-PC, because the biomarker is not specific for ALD. And all this on this little blood spot over here, which is 3.2 millimeters or 1/8 of an inch in size. And what we came up with is make use of the simple fact that males have 1 X chromosome and a Y chromosome, and females have 2 X chromosomes. So the ratio of the autosomes, chromosome 1 to 22, compared to the X chromosome is 2 to 1 in males, and it's 1 to 1 in females. And you can test it because there are little pieces of DNA that are present on some of these chromosomes that are also present, identical, on the X chromosome. But of course, this test can go wrong. Something can happen. So we developed a test in which we do this 3 times. So we measure the ratio of chromosome 2 to X, 3 to X, and 7 to X. And this looks like this. So if you do that, if you amplify this piece of DNA and you look at the size of it, then you see that in males you have a ratio 2 to 1, 2 to 1, 2 to 1, and in females you have 1 to 1, 1 to 1, and 1 to 1. So this test allows identification of individuals with 1 X chromosome. So this is the algorithm, the ALD newborn screening algorithm that is used by many states in the US. And there are different flavors of this, but this is the algorithm that's used by New York State. And so we changed this and we added this X counter, as we call it. It's a 2nd tier test. So we have a 4-tier test. Also, in the Netherlands, parents of girls are asked if they want to participate in the pilot, because if you have a baby girl, you may, and you're asked, you may think, well, why should I participate in this trial? But if we only would have boys, we can never test this algorithm. And also in the Netherlands, parents give informed consent to participate in the pilot. And we started screening January of this year. It's rather complex, not just because we have 4 tiers, but also because, as I mentioned, the blood spot cards are screened in the newborn screening labs. 2 are participating. Then the screen positive cards, which have elevated C26 lyso-Pc, are sent to the AMC, to the Department of Clinical Genetics. There the X counter is done. If there's 1 X, then a 2nd blood spot is sent to our laboratory, where we again measure C26 lyso-Pc, but now at much higher specificity. If it's positive, then this DNA from the X counter, we still have some left, is sent to the lab for sequencing. And if there's an ABCD1 mutation, we have a boy with ALD. In all other cases, we have to stop, because that was our task. That was not our choice, but that was the task given to us. And oh yeah, to make it a little bit more interesting, we have to do this within 35 days, because newborn screening can take 35 days at the most. So we are now 5-6 months on the way, and so far we have screened almost 30,000 newborns. This is just a plot to show you the C26 lyso-Pc in the general population. We started off with a cutoff of 0.28. We could have done a little higher, but the task was to test this algorithm. So we want to have a certain amount of samples going through to the tier 2, 3, and 4, or at least to tier 2. But in January and February we had too many samples, so we had to increase the cutoff to 0.32, which is still way below the ALD samples that we tested in the validation stage. So from the 30,000, we had 486 screen positives in tier 1. That's about 1.55%. And from these, we did have the X counter, so we know whether these are boys and girls. And we were a little afraid that parents of girls would say, well, we don't want to participate. And because now we know these 486, if they were boys and girls, we can go back. We can also go back to the tier 1 data. But 2 things. The first is that we consistently have more girls in our test than boys every month. And another thing, as I mentioned, we have the tier 1 data, so we could also look at whether there would be a difference in C26 lyso-Pc between boys and girls in tier 1. And that is not the case because the measurements completely overlap between boys and girls. So now we have these screen positives here of these boys that are identified in tier 2, and they go to tier 3, measuring again C26 lyso-Pc. And for those, we have now 218 samples measured. This is the data from tier 3. This was data that we generated in the validation stage. So before we started screening, we analyzed over 200 random newborns, and based on that, we set up a cutoff for tier 3 at 0.150 micromole per liter. We, with the help of New York State and some of our own Dutch patients, we had 8 samples. Here are 9 samples from ALD newborns for which we had blood spots. So we could measure C26 lyso-Pc in tier 3 with this measurement, and you see that there's a nice difference between range between the controls and the ALD newborns. So this is the results that we have since the beginning of January. So these are all boys that were positive in tier 1 and that were boys in tier 2. And you can see that we have 5 samples that were over the cutoff. So these were tier 3 positive. These were sent to tier 4 for sequencing. From these 5, 4 were negative, so there was no ABCD1 mutation. Well enough, these were all below the lowest ALD boy we had found in our validation. And we had 1 boy that was positive for ABCD1. It's also in the range for ALD. And so we had this family was referred to for follow-up. So this is the very complicated newborn screening process in the Netherlands, and I will not go in it too many details. But important, as I mentioned in the beginning, information for an informed consent is important in our screening program. And I mentioned information, so we also have a website about the pilot. It's in Dutch, but because we need to provide information about what we're doing. So this family with a positive tier 4, they are referred to our institutes in Amsterdam, the Amsterdam Medical Center. We are the center of expertise for paroxysmal diseases. So what happens is that the medical advisor of the newborn screening program contacts the pediatrician at the AMC, and at that moment already an appointment for the family is scheduled. Next, the medical advisor contacts the family physician and provides information about the disease that the family physician needs to, the message need to give to a family. So the general family physician is a little bit informed about the disease. Then the family physician contacts the family, and if needed, the pediatrician is on call. Since we have some time with ALD, we decided that we will never do this on a Friday, because we don't want Dr. Google in the equation. So in general, this is done on a Monday or on a Tuesday, and then on the next day, the family can already come to the institutes, and so they meet with the pediatric neurologists, which sometimes is Mark. Then a blood sample is taken for confirmation. Was there no mix-up? And we also have a follow-up protocol. And what is important is that in the Netherlands, newborn screening, follow-up, and treatments are all covered by our health insurance. This is the follow-up protocol that we have. So this is the Wednesday that the family meets after the notification of the positive ALD screening result. The blood sample is taken, it's sent to the lab. We do it again. We measure again the lyso-Pc, and we check the mutation. Then the family comes to the institute again. They get more information. They can ask more questions, and then the schedule for the follow-up is made. And when the family comes to the institute in the morning, they start with an adrenal test. Then they can meet with the clinical geneticists to talk about extended family screening and all the reducive options and the consequences of this genetic disease. And there will be follow-up, and this will continue. We also have a system set up in case we end up with a mutation that is not yet identified before. So the positive ALD screening, if we have an ABCD1 mutation that is already in the database, it's a confirmed pathogenic mutation, we have a diagnosis of ALD. In case it's a variant of unknown significance, there are two ways we can go. We can do extended family screening, try to identify a male with the same ABCD1 variant, then measure C26 lyso-Gb-C, should be elevated in all males with ALD. So if it's a yes, we have a diagnosis. Wait a minute. No, if it's not elevated, it's no ALD. If it's I'm going the wrong way. Wait a minute. We use a. I'm lost here. We use a male, and if the male has elevated lyso. Oh yeah, yes, we are here. If in an adult male there is no elevated lyso-Gb-C, we have a no, and we have no ALD. And then it's also concluded that it's no ALD. If this is not available, then we have the functional testing that we can do. We can take a skin biopsy, grow fibroblasts, skin cells, and then do a bunch of assays to see if this is a functional mutation. This all is published. It's open access. So if you just look for a scan study or or us, then you can read about this whole study. Well, many people are involved in setting up the ALD newborn screening. This is the ALD group in Amsterdam, and thank you for your attention.
Who's going next?
Troy, I think.
All right. Get my presentation loaded up here. Share screen. Okay. Can we see my screen okay?
Yes.
All right. All right. Well, I'm always happy to be here and kind of update everybody on transplant. My talk is really going to be just generic. It's really derived from a lot of the questions that I get about transplant and transplant logistics. And I'm going to have very little data and really no scientific presentation, but really just focus on what is our mainstay treatment for cerebral ALD. I only have about a dozen or so slides. So this is really geared towards the families heading into transplant or thinking about transplant or have questions about transplant. Here. Okay, so why are we offering transplant for ALD? Everybody more or less understands that it's an option once you develop cerebral disease, but the data really goes back to this excellent article in Lancet Neurology. If you look at boys with cerebral disease, and you look at those that were transplanted, that's the blue top line up here. This is a survival curve, and their survival is close to 100%, so 95%. And if you look at boys with ALD who did not go through transplant, you can see they ultimately deteriorated and lost their life to the disease. And this separation or this difference in outcome is really the main reason and a great piece of data to reemphasize why we have transplant, and now we can include gene therapy for cerebral ALD. because we want to not be on the red curve here. We want everybody on the blue curve at 100%. So, and many times the families like to discuss, you know, a lot of the questions come about, you know, what do you look at for these boys? We always talk about the LESS score, and we always talk about function. We talk about gadolinium. So the scores that everyone is talking about are these, the damage that we see in cerebral ALD as indicated on MRI. And the damage is really indicated by this whitish region here, and here. This is the corpus callosum, and here that's abnormal brain. And you can enumerate a lot of the different brain structures by how much damage you see. And so it's not really about area, which is what a lot of families think. It's really about numbers of brain structures, and you have to know a lot about neuroanatomy to count these structures up. But that's where the score comes in. So you can have a high score with lots of structures, but a very low area, or you could have a low score with a very large amount of brain involved because it's only one region. So these are examples of scores of 1 here, far left, 1.5, kind of the middle here, a score of 3, shown here near the right, and then a score of 7. And the 7 and the 3 look similar, but when you start looking down in the midbrain region, you actually get a lot more points. And in this region, there's a lot more neuroanatomy structures. So if that's involved, the points go up pretty quickly. And so that's how some kids can have a pretty high score. So it does depend a lot where the brain is involved. So then there's the gadolinium part, and this is really just a measure of inflammation for us in the brain, and we use it as an activator of or a descriptor of active inflammation, active cerebral disease. And this is the dye or the gadolinium that's given during the MRI through the IV. And if you have active disease, it leaks out of the blood vessels and enters the brain, and it's not supposed to do that. We have a very crude scoring system for it. It's 0, 1, 2, and 3. It's as simple as that. 0 means you have no enhancement, no gadolinium enhancement, and all of us should be at 0. And then we just really grade the brightness of this whiteness here. And what the arrows here are pointing to is the GAD enhancement. And we compare that to the arrowhead, which is a small organ in your brain called the choroid plexus that makes spinal fluid. It has a brightness to it, and we just compare it. And we say a score of 1 is a dimmer, a gadolinium enhancement that's dimmer than the choroid. If it's a 2, it's the same. And here on a boy that's a 3, his gadolinium enhancement is brighter. So we use that score when we are assessing boys for transplant. Not everybody uses the score, but we found it can correlate with gadolinium resolution after transplant, and does correlate with some of the blood and brain biomarkers that we've discovered. So we use it. The other thing we work up boys with is the neurologic function score. That's really an assessment of how a boy is doing neurologically. You get points for dysfunction or problems. So in this case, if you have a boy that has hearing problems, it's a point. A boy that has loss of communication, it's 3 points. Visual problems is a point. If you're blind, you have 2 points. Actually, the points are additive. So if you're blind, you get the 2 points from being blind, but you also get an additional point for the field cuts. So they go together. So you actually get 3. Tube fittings, 2 points. Running, walking, spastic gait, the points go up. Wheelchair, 2 points plus the others. It's not a linear score, as I've pointed out. It's not perfectly validated, but it does help us categorize patients in terms of where they're at and what do their outcomes look like. I would say in general, a score of 0 to 1, maybe 2 is acceptable. Once you're beyond that, things don't seem to go as well for kiddos after transplant, for sure. And so we want to catch them as early as possible. And we heard in the previous excellent talk, we have newborn screening to do that. So what is the goal of transplant now? Now this is a boy with cerebral disease. This is the gadolinium enhancement. We would call it a Garland ring enhancement. Here on his brain, you can see it. It's just a nice little ring. And 28 days after transplant, it's gone. So that means the blood-brain barrier is somehow repaired or sealed, and we've extinguished the active inflammation of the disease. So that's the whole goal of transplant and or gene therapy, is to arrest this process as quickly as possible with the least amount of progression. I'll also remind the audience that the cerebral disease injury, so the damage that a boy comes in with or has developed, that stays. So this T2, call it T2 weighted imaging, indicating the damage here in the corpus callosum, that is lifelong. That is not going to go away, nor does it change. The goal is to keep that from expanding and taking over the rest of the brain structure. And so that's, so we arrest the process, basically. Disease burden plays a big role. So here's our scoring system put to use, and this is a survivability after transplant. Kiddos with a score of less than 10 do exceedingly well with great survival, 90% plus. If you're greater than 10, you have inferior survival. Survival rates down to 60% or even down to 50%. So again, catching disease early when you have that score of 1 to 2 is ideal. A couple other outcome predictors. On the left is C, you see kids with a score of less than 10 who had a sibling transplant had 100% survival. And this is the meter stick against which we test all therapies, including cord blood, unrelated donor, and gene therapy. And if you had an unrelated donor, transplant outcomes were slightly inferior, with survivability at 80 to 90%, closer to 80% actually. And then what about the role of N-acetylcysteine? I get a lot of questions about that. We do have some kids on it. We use it peri-transplant often. And this is why. For very advanced kids with scores of 10 or greater, the survival is 90% in those boys if they're on N-acetylcysteine. But if they're not on it, the survival was much, much less. The problem with data like this, which is getting on in years, is that this is just being alive. I'm not telling you about what kind of shape these boys are in. So oftentimes boys, when their less score is 13, 14, 15, they may be alive, but they're often non-communicative, bedridden, diapered, often G-tube fed. So something has to be said for the quality of life. You have to be, it'd be nice not just being alive, but also being in good neurologic shape. And so that's what you don't see in this graph, but it does answer the question about the role of N-acetylcysteine, and it can modify outcome. So one piece of a data slide, neurofilament light chain, which is very popular to discuss in the neurologic disease realm these days. Johannes Berger's group put out a very nice paper outlining its role as a biomarker in X-linked ALD. And it's really nice to see. Most of those patients were AMN patients and adult patients. And at the same time, we were actually looking at it in our patients. The nice thing is that it is in the plasma, or it's in the blood, so you can do a blood draw. And I will just show you two pieces of data. We did measure it in the CSF and found it is very elevated in the CSF of boys with cerebral disease. And then I'm not showing you the plasma data versus the controls, but it's also elevated. But I just do want to comment, we did look at boys pre and post transplant at their plasma neurofilament light chain, and you can see actually decreases at when we measured at 1 year post transplant. So it's in really nice agreement with Dr. Berger's data as well, and that decrease was roughly 50% from their baseline to when they were measured again, which is 1 year after transplant. And that was seen in 10 of the 11 boys, but one boy actually had an increase. I can't really explain why that is. I tried to look in really at the details, and I don't have any good explanation on it. But overall, most of the boys dropped 50%. So that's really the data I wanted to show. But I do, again, want to get back to answering many of the questions I get about transplant. You know, we call this hematopoietic stem cell transplant, bone marrow transplant, stem cell transplant, umbilical cord blood transplant, gene therapy transplant. These are all the terms that are thrown out there. Some are very similar, some are not. Essentially, it all depends on the cell source. So we have autologous gene therapy, that's using your own cells in a transplant. We have allogeneic transplant, which is using a related person, brother, sister, sometimes a parent, or an unrelated person. That's somebody out in the world identified to be the match, and maybe in a different country, on a different continent. We also use these terms matching or mismatched. So we look at the proteins and we try to match persons by these proteins on your cells. Commonly, we use the term 6 or 8 or 10 matches. These days, 10 is the most common, and the more often you match, the better the outcome. So we try to go for an 8 of 8 or a 10 of 10 match. Sometimes we have to accept some mismatch. But we can still do transplant with mismatched stem cell sources. Then we have the source of the cells. I talked about the autologous, which are your own cells, but there's also umbilical cord blood. There are over 1 million units in storage around the country, and those are available within 1 to 2 weeks of shipment. You can also use peripheral blood. You can actually give a drug called GCSF to a person, and the stem cells enter the circulation and can be drawn off through a centrifuge. And then there's the classic marrow, where somebody goes to the operating room and we draw the marrow out, put it in a bag, process it, and then infuse it into the recipient. We do that all on the same day. And if it's even in another country, the marrow is shipped first class to its country of destination and delivered as fast as possible. There's another type of transplant I won't discuss, syngeneic. It's just another term. It's a twin-to-twin transplant. Those are rarely done anymore, but they were the first kinds that we were experimenting with back in the 1950s. So what's involved in a transplant for boys with cerebral disease? Well, there's a workup. And in that workup, there are many parameters. This is just what I look at amongst a few things. I look at the LESS score, we look at the GIS, we look at the neurologic function score. There's the overall health of the child to consider. Does the child have other diseases or other problems? Has the child had major infections? Do they have adrenal insufficiency, et cetera, et cetera? All this is part of the workup and the assessment. It's just not just one thing. So logistically, it takes about a week for us to do a workup for a child destined for transplant. So again, we look at the disease status in multiple parameters, including symptoms, LESS score. We measure CSF protein and some biomarkers. We do look at the HLA matching that I just discussed. We look at what donors are out there. Is there a brother or sister available? Is there somebody in the country available? Is there cord blood available? Or is there a clinical trial open, such as Bluebridge gene therapy? We assess the heart, lungs. We assess the patient from top to bottom, kidney function, everything to make sure they're in good health. And we check them for past infections, and there might be other risk factors. This becomes more important when you're working with adults with cerebral disease who are eligible for transplant. Adults might have like a smoking history or might have emphysema or a heart history. That plays a much larger role in predicting outcomes. So what does the whole process look like of transplant on a slide? So after the workup, which I said takes a week, a child gets a central line placed, which is a large bore IV placed in the chest into one of the large vessels so we can deliver chemotherapy and the transplant. That happens 1 day prior to chemo. The child then gets chemotherapy per whatever regimen is being used. That's 6 to 8 days often. That is now done all in the hospital. Then there's transplant day. We call that day 0 because that's the day you get the cells infused. And then everything after that is post-transplant day 20, 30, 100, whenever. There's then the recovery period. Since this chemotherapy is myeloablative, that is, it wipes out your entire immune system, and there's no chance that it really is going to regrow. So you're waiting for the stem cells to take hold and regrow that immune system. That waiting period or recovery period in the hospital is roughly 14 to 28 days after the transplant. This is when we're watching for the side effects. The most common ones are hair loss and mucositis or mouth sores. You can get fevers, you can get nausea, you can get infections. We're looking for complications from the chemotherapy, kidney problems, lung problems, etc. And then you meet criteria, are discharged out of the hospital, and then you go to clinic every day while you're being closely monitored, then every other day, then every third day, and then you get down to once a week in the clinic. And then our criteria are you can return to your home city or home state or home country about 60 to 100 days after the transplant with close follow-up at your home clinic. You'll return to the transplant center roughly every 6 months for the next year and a half, just for evaluation of both your cerebral ALD, but as well as your overall health. The other common question I get is, what about gene therapy? What about transplant? What's the best treatment for my child? And it's hard to say that anything is truly the best, but what I've tried to do over the last year or two is start building a slide of what are the things we look at, what do we discuss during meetings with families, and how do we compare the two things? And again, this is after hundreds of questions about this gene therapy and our other type of transplant. So do they both involve chemotherapy? Yes, it's the same thing. The cells in gene therapy are your own cells. The cells in the allogeneic transplant are not yours. They're somebody else's, brother, sister, somebody out in the world. The recovery in gene therapy generally is faster because it's your own cells, and for an unrelated, it's slower. GVH risk in gene therapy, there is none noted to date in any trial. And in allotransplant, it's roughly 15% risk of a mild type of GVHD. And I'm not going to go into the details of GVHD today. Is it possible to progress after therapy? Yep, you can progress after using therapy, and you certainly have a risk of progression after unrelated therapy. There's no risk-free non-progression. Gene correction. So in gene therapy, roughly 15 to 40% of the cells are corrected or have the correct copy of ABCD1, and in an allotransplant, that's 100% because that donor does not have ALD. Durability, gene therapy is still in clinical trials, or the trial is recently closed. So the durability is unknown, but the first patient is probably around 5 or 6 years out now. And most of the children, as Dr. Ackley pointed out, are doing quite well, and most of them are stabilized. In allotransplant, there's no risk I've ever seen after transplant. And so that's what we know about it. Risk of cancer for chemotherapy. Yes for gene therapy, yes for allotransplant. We are using myeloablative toxic agents that break DNA, so there'll always be a risk. Risk of cancer from gene insertion. So gene therapy involves breaking your own DNA and inserting a virus carrying a copy of the ABCD1 gene. So there can be a risk of cancer from that process if it lands in an oncogene, perhaps. We've not seen this in any boy with ALD, but the risk will always be there. This risk is absent in an unrelated donor because we are not inserting anything into the genome. And this is, I should mention that the gene therapy models we use now, or the treatment, are as safe as we've ever produced. We're on the 3rd or 4th generation of the virus that integrates itself. So it's as safe as we can possibly be for now. Are there fertility issues in gene therapy? Yes, and there are also fertility issues in allotransplant because, again, it's the same chemotherapy. Overall risk of death from therapy. In gene therapy, it's going to be lower because it's your own cells, and those transplants just inherently have a lower risk of death. In an allotransplant, it's going to be higher. There's always going to be a risk of complication. Even if GVH is mild, even if it's 10 to 15%, yeah, you could never promise somebody that there's no risk of death in therapy. So all put together, that risk is going to be probably a little higher in an allogeneic transplant setting. And again, in the auto transplant setting, that risk inherently is lower. It doesn't matter if it's gene therapy or if I'm doing an auto transplant, even for another disease, that risk is lower. Risk of AMN later in life, unknown in gene therapy. It's hard to answer if that's going to be helpful. And even the same for allotransplant. I'd say, yeah, I can't say there's no risk. There's possibly some of these boys post-transplant will get AMN. There's a nice little paper from the Dutch group that described 3 boys that had AMN in their 20s, and they were 15 years out from transplant, as I recall, or something about that. So I'm going to have to say possibly. Practical things. When does that central line come out of the child? Gene therapy, day 60. Allotransplant, 6 months, so day 180. Other practical things. There are medications to prevent rejection and side effects that are used in allotransplant. Those medications are not used in gene therapy. So I'll have to add a new line actually discussing the numbers and the amounts of medications used in each protocol, because they are different, with less of them used in gene therapy. Estimated cost, well, gene therapy products are probably going to be $2.5 million from what I'm reading in Wall Street Journal, which is roughly could be 5-6 times more expensive than a traditional sibling transplant, which is $400,000 to $800,000. So this is where third-party payers and insurance companies are paying very close attention to try to decide risks benefit when you bring cost into the picture. But a lot of this cost has not been sorted out quite yet. And so that's all I'm going to talk about on transplant today, and hopefully we'll have answered some of the family's questions about it, and then I'll turn it back over to the team.
So good afternoon, everybody, or morning or evening, depending on where you are. I think this is the last talk of the session. And like Troy, I made my talk about a subject that I get lots of questions on in clinic. So I hope it will be useful for at least some of you. And I would like to focus on the leukodystrophy of XALD, cerebral adrenoleukodystrophy, and how we monitor it and what we think is the natural history. So what was already clear from the previous talks, the onset of cerebral ALD is unpredictable. We don't know which of our male patients will get it, and we don't know when they will get it. And we estimate that about 60% of men affected with XALD will develop it over the course of their life. And it was originally thought that cerebral ALD was really a pediatric disorder, and that is kind of true in the sense that it's probably more prevalent in boys of school age and adolescents. But as you can see if you look at the red line, which is the survival curve for cerebral ALD, you can see that although there's a sharp drop here before the age of 10, it starts to decline still gradually over life and also way into adulthood. So it is not true that adults can no longer get cerebral ALD. So this is going to overlap a little bit with Troy's talk, but how does cerebral ALD manifest itself on MRI scans? Well, more than 80% start in what we call the splenium of the corpus callosum, and then extends into the occipital parts of the brain. So here's the eyes and nose, and this is the back side. So that's where it occurs more often. And it also is characterized by active lesions that are still growing, are characterized by this leaking of gadolinium, what we call enhancement. And this is a very typical scan. If you see a scan like this, it can not be anything else but XALD. There's also the possibility that it starts in the front of the brain, in the genu of the corpus callosum, and extends further in the white matter. That's about 20%. And there's also very rare forms that start in other parts of the brain. The problem when diagnosing it, because like Troy said, it's very important for us to know if the lesions enhance or not. This enhancement can be very prominent, like in this scan, everybody will see these white lines, but it can also be very subtle, like here, which on your screen is probably hardly visible. So it's very important to give a high dose of gadolinium and wait for a long time, 5 or 10 minutes, because otherwise you can miss this kind of subtle enhancement. Well, what is less well known is that cerebral ALD is not always relentlessly progressive without treatment. Lesions can sometimes arrest spontaneously. This is a scan from an adult man who had not been receiving follow-up for decades. And when we scanned him, we found these large lesions that were not clearly symptomatic. He was doing quite well at the time. And after gadolinium contrast, there was absolutely no enhancement on this T1 weighted image. And indeed, follow-up scans were completely stable for years. And this is probably not very rare. The only problem is when you find a small lesion that is enhancing, you cannot predict whether it will spontaneously arrest or not. And because Troy clearly illustrated that if you perform the transplant at a later stage, the outcome is much worse, both morbidity and mortality. So you do not have the luxury to wait and see how it will develop. But probably this arresting is not as rare as we thought. Well, this again is unfortunately a little bit of repetition, but you will hear a lot of LUS score. And basically the LUS score is just turfing where the ALD lesions are. So on the MRI scan, you identify the anatomical structures, like here the splenium, and if it's affected bilaterally, you give 1 point. If it's affected unilaterally, you give half a point, and you work through the entire list of anatomical structures, and then you end up with a score between 0, normal, or 34, in which virtually all the cerebral white matter is affected. So the fact that cerebral ALD occurs in adulthood is not new at all. In a paper from Björn van Geel, when he was at the Kennedy Krieger Institute, already based on a retrospective study, showed that especially younger men under the age of 40 were quite often affected. And that is something that's in other cohorts was reproduced. And in the larger cohorts, there's even cases of men above 60 or even 70 who develop cerebral ALD. And interestingly enough, sometimes there's a trigger. This is one of our patients who developed a small stroke, small white matter stroke. And in the 6 months after that, he gradually declined. And on the MRI scan, there was found that in the area of the small stroke he previously had, he had developed a very asymmetrical cerebral lesion. So stroke or trauma can be triggers also in adults. Yeah, there are reports of cerebral ALD occurring in women. Personally, I had never seen one until a few months ago, when one of the women we scanned for a study showed this very clear ALD lesion, which is non-enhancing and is so far not progressive. So very rarely it can also occur in women. Well, a few years ago, it was unclear whether hematopoietic cell transplant would also be beneficial to adults, but well, it was mentioned in the previous talk and also by a research group from Germany. It turns out that hematopoietic cell transplantation works for adults as well. There's just a catch. Adults have a much higher risk of complications, and because the spinal cord disease is usually manifest in adults, especially in older adults, that can be a complicating factor, because people who are not ambulatory because of their spinal cord disease and who have severe bladder dysfunction, which necessitates indwelling catheters, will get horrible complications. So those people are probably not, for those people, the transplant is probably not beneficial, but an adult who is in otherwise good health and is ambulatory can certainly be considered for treatment. So because there is a treatment for cerebral ALD, and because the results are best if you find somebody who has only an MRI lesion and has a function score that is maximal, people get frequent MRI checkups, and well, in most parts of the world, small children, for instance, roughly between 3 and 12, although that varies locally, are scanned more frequently because the incidence of cerebral ALD is higher, so twice yearly. And in adolescents and adults, we generally do it yearly. And we used to give gadolinium contrast to every patient we scanned, but because there are now reports that gadolinium does accumulate in the body, we actually now do scans without gadolinium and have patients come back if we find a lesion. So, as we mentioned, there's a recent study by Eric Malik and collaborators that this prevalence of this so-called arresting cerebral ALD is actually not that rare. By combining a few cohorts, it was estimated that it could be as high as about 15%. So these lesions can stabilize, but as we mentioned previously, you can't wait to see if they stabilize or not. But if you scan adults that had been out of follow-up, it is not very rare to find lesions like this, which look very old and inactive. And these lesions can be stable for many years. However, unfortunately, those stable lesions can start to become progressive again during life, so they can reactivate for unclear reasons. This is an example from a recent paper. So, for instance, here you see scans of a patient who has these clear frontal lesions with no gadolinium enhancement, and a few years later on follow-up, you see that the lesions have increased. This is not very visible on your screens probably, but there's very weak gadolinium enhancement. So this arrested cerebral ALD is something that you could also consider for low frequency follow-up. Well, the only tool we used to have to monitor patients for cerebral ALD was MRI scans. And of course symptoms, but MRI scans are abnormal way before symptoms arise. Recently, the paper that was also already mentioned was published that this compound in CSF, but also in blood, called neurofilament light, is a pretty good marker for neuronal damage. And it is increased in all patients with XALD compared to controls, but especially in those with active cerebral disease. You can see that in patients with spinal cord disease, with AMN, on at group level, it is different usually from controls, but especially those with active cerebral lesions have incredibly increased value. So it's likely that neurofilament light measurements is something that will be used more in practice, and especially if you have ambiguous MRI results or if you're not sure if there's enhancement, this can be an extra clue whether you can wait or not. And this is some of our own data, which also nicely supports what other groups have reported, that the higher the LUS score, so in active cerebral ALD, the red dots, the higher the LUS score, the higher the neurofilament levels. And in inactive arrested cerebral ALD lesions, the blue dots, you can see that the levels are very low. So this is something that could be useful. Oh, sorry. So to summarize, cerebral ALD occurs in adult men also, and MRI follow-up, I think, is also warranted for adults. Unfortunately, we lack the specific knowledge to predict who is at risk, so we are forced to scan everybody. Of course, we would prefer it if we could distinguish high from low risk so that we would not have to expose everybody to the intensive follow-up, but we're not there yet. And in adults also, a transplant can be considered if somebody is in physically fit condition, and lesions can spontaneously arrest and reactivate, but we need to know more about that to understand why this happens and to better predict in whom it will happen. And neurofilament light is a marker that seems useful in the follow-up of ALD, especially for patients with cerebral disease, and we'll see how that plays out within the next couple of years. So this is what I wanted to talk to you about, and if there's any questions, I will do my utmost best to answer them.
Okay, we do have a couple of questions so far in chat. Dr. Kemp, do you want to ask Dr. Lund your questions?
Yes, I was wondering, because I was talking about newer screening, and then I thought maybe it's too early, but do you see more kids being referred for transplants now that there's actively a newer screening? And yes, and if yes, I also assume that they are in a much better condition. Of course, it should be, or is it too early?
Yeah, I would say definitely the numbers are up. Are there more transplants? Not yet, but we have this comprehensive ALD clinic, and I would say the numbers of babies obviously shot up tremendously. And so we follow all these kids. Now, we've been at it about 4 years. And so just given the numbers and how they come out, some of those kids are going to convert in the next 2 years. And I imagine that's probably true in New York. They've been at it, a bit longer than us. So I think we're now at that turning point where, we're going to start seeing those conversions and then more transplants or gene therapy.
Thank you.
Next question we have is there an estimated cost per session of gene therapy? My insurance will cover a certain amount per session.
Not that I'm aware of. It is not an approved medicine yet, and so it's not technically available. Once it becomes approved and then can be marketed, and then at that point the cost will be decided upon by the company, and probably in some negotiation with the payers or the insurance company. And certainly anyone else that has more information on this topic is welcome to answer.
Okay, and the last question that we have in the chat is, can NFL on its own be an indicator of onset of cerebral ALD?
I'm trying to think if we've done that prediction type of an experiment. By and far, what we do is group patients into those with cerebral disease and those without ALD, and we see a very nice separation. What you'd want is sampling every year of a person or a child, and then when they convert, sample again to see if NFL had gone up or even preceded. What about your group on the other side? Have you looked closely at that?
No,
not saving. Oh, Mark,
no,
you go.
No, not yet. We don't have enough observations yet.
No.
You saw the graph with the few dots in it, but it's just very few dots. So I wouldn't be comfortable skipping the MRI just yet, but who knows, if we have much more data, maybe it'll turn out to be very sensitive. But like Troy said, we need longitudinal data for that.
Yeah, it is a nice biomarker, though. It's very sensitive and it responds to therapy, at least in most. So we haven't seen that before. Usually I'm looking at biomarkers that go way up, and then after transplant, they don't move much. So they didn't predict anything. But neurofilament light chain is different in that regard. And so I think there's promise there. So I agree with you.
Okay, well, we're quickly approaching the top of the hour, and that is when the industry panel will begin. So if there are no further questions on the ALD presentation, I will let Dr. Fatemi facilitate the industry panel.
Okay, great. Thanks, Didi. Yeah, so why don't we get started? We have, if I'm not mistaken, 6 company representatives for 6 different corporations that are having a research and development plan for ALD or AMN. And so I think they all just turned on their cameras, so that's great. And we have basically an hour. My understanding is there's a hard stop. So basically the idea here is to have each company present briefly over a few minutes their program, and have a few minutes left over for questions at the end. Perhaps we save the questions all the way at the end if everybody agrees on that. And I think we should just do it alphabetically. So that's the most fair without us giving any company any preference. So alphabetically, I guess the first company would be Autobahn. Maybe it's Ashwata. I'm not sure. I had it in my mind it's Autobahn, but I think it was actually Ashwata. So why don't we start with Autobahn? I just had it in my mind that way. Sorry, I think my English is wrong. But go ahead, Rohan. Are you presenting for Autobahn?
Yes, I am, Ali. Can you hear me okay?
Yeah.
Perfect. Thank you so much. Just a quick thank you to the organizers of the United Leukodystrophy Foundation for inviting us. I think this is going to be quite an interesting session, and I hope this is useful for the families just to get an update on, what we in industry are working on. I'm just going to share my screen right now. Sorry, 1 second. Okay, are you able to see a single screen or 2 screens?
It's a single presentation.
Okay, perfect. Thank you very much. All right, so just a quick introduction. My name is Rohan Gandhi. I'm currently heading up medical affairs and scientific affairs at a company in San Diego. Innovating creations of the next generation of treatments for central nervous system disorders. So we have a brain targeting chemistry platform that is based on a small molecule prodrug technology that delivers very potent active molecules to the central nervous system. And we have very high confidence in the biological pathways that we've chosen to target, primarily because we've chosen these targets based on evidence from human genetics. And we really plan on focusing on a biomarker-enabled clinical development strategy to let us know as we continue to develop these molecules that we're actually being able to have an effect in these biomarkers of these diseases. I mean, ultimately, our goal is to drive regeneration in the central nervous system by harnessing these endogenous mechanisms to try and allow them to Our lead program is called ABX002, and it is for adult male patients suffering from adrenomyeloneuropathy. And we've completed our IND-enabling toxicology studies and will be initiating our first in-human clinical trials by the end of this year. Okay, I'm going to go a little bit fast. I'd like to finish this in 10 minutes so we can have questions at the end. But really what we're trying to do is we're trying to generate at least one program every single year. And what's depicted here is that at least for 2021, we're solely focused on bringing the ABX002 molecule forward for patients suffering from adrenomyeloneuropathy. So we're planning, as I said earlier, in the fourth quarter of this year to initiate a SAD/MAD study. I can go into the study design a little bit later, but this will be our first in human in healthy subjects at the end of this year. Behind this program, we have additional programs. The only one I'll mention right now is ABX003, and this is for patients suffering from multiple sclerosis. This program is at least 1 year behind our program for adrenomyeloneuropathy. I won't spend too much time on this slide, just to let you know that we're focused on CNS disorders. Some of these are rare, such as AMN. Some of these are somewhat prevalent, such as multiple sclerosis. And we've got a whole pipeline of molecules behind this as well that we haven't disclosed as yet. I did want to spend just a minute on this slide because I like the way that it depicts what's different about our technology. So we have a technology that allows us to deliver very potent molecules to the central nervous system. Now, how do we do that? So this cartoon kind of depicts the brain with a blood-brain barrier. And this is a very simplified view of what we're attempting to do. But in general, the blood-brain barrier, we've developed this blood-brain barrier through evolution. And it's been conserved because it prevents access of foreign materials into this very important chamber, the central nervous system. And so a lot of molecules either have a negative charge or a positive charge, and they're not allowed to diffuse into the central nervous system. So what our technology does is it actually takes these negatively charged acidic moieties that were developed for thyroid hormone agonism and converts them to a neutrally charged amide. So this is the prodrug. This neutral charge of the molecule then just allows these molecules to passively diffuse into the central nervous system. And once they get there, they're actually encountered by an enzyme called fatty acid amide hydrolase, or FAAH. And once FAAH sees the prodrug, it basically cleaves the prodrug and allows the active ingredient to be delivered in the central nervous system. So this technology allows us to tune the distribution of our molecules to different areas. So we can either control, we can identify molecules that have a greater penetration into the brain, for example, or we can look for molecules that have a balanced distribution that go into the brain and to the plasma equally. And we really feel that for a disease like AMN that has dysfunction both centrally but as well as peripherally in the adrenal glands and the testes, a balanced exposure distribution would be preferred. I'll just quickly mention that we're using multiple approaches to tune the central versus peripheral distribution of our compounds. The one that I already described to you on the left is this brain targeting prodrug technology, but we've also recently accessed a clinical stage peripheral FAAH inhibitor. So remember, this is the enzyme that actually cleaves the prodrug and allows the active to be present. This enzyme is actually even found in the periphery. So if we want to really push the work only in the central nervous system, we can block the activity of this enzyme peripherally by combining these two molecules. Okay, I want to quickly transition to the pathophysiology of adrenomyeloneuropathy. I won't spend too much time on the left-hand side. I think you all are quite familiar with the genetic dysfunction here, the lack of the ABCD1 gene, leading to a buildup. I think it was Dr. Fatemi who actually presented this earlier in the AMN session, as well as Dr. Jerry Raymond. So these VLCFAs, these very long chain fatty acids, basically build up in the cytoplasm and become toxic because of their accumulation. We're pretty excited about our compound because we feel there's two mechanisms that might be at play here. One of them is that this compensatory transporter called ABCD2, or the gene product of ABCD2, which is the adrenoleukodystrophy related protein, may be driven through the thyroid hormone gene system. And so because we're using these thyroid receptor agonists, when our compound is delivered, it will go into the nucleus and drive thyroid hormone responsive genes to be induced. And one of them will be this compensatory receptor called ABCD2. So even in the presence of an ABCD1 dysfunction, we're hopeful that we're able to drive ABCD2 upregulation, which will help clear those accumulated DLCFAs through the peroxisome. The other mechanism which we believe might be beneficial is that of the role of thyroid receptors and thyroid biology in driving remyelination of both central and peripheral axons. Okay, I won't spend too much time here other than to say that we're really focused on compounds that we've identified that have a very balanced exposure, and that's kind of shown over here. So these are compounds that have the ability to get into the brain, but also to distribute peripherally. Some data on our compounds. So our compounds, at least for ABX002, it's a very potent and a highly selective thyroid hormone receptor beta type agonist, and it has a balanced distribution. So we've designed these molecules to be more selective for thyroid receptor beta than for alpha, because some of the some toxicity can be driven by driving the alpha system, and specifically toxicity in heart and bone. And when you look at the tissue distribution of our lead molecule in a monkey, for example, you can see here that the active acid present in the tissue versus plasma is over 1. That means if it's 1 or higher, it has a balanced distribution in that organ. So we have quite a bit of expression in the brain, quite a bit of distribution in the brain, quite a bit of distribution in the spinal cord. We also get our compounds into the liver, but we're being pretty good at keeping these compounds out of the heart.
Rohan, it's 1:10, so please, just maybe 30 more seconds or so.
Yeah, perfect. Maybe, yeah, thanks, Dr. Fatemi. Maybe I'll just end to say that, we've been focused over the last 1.5 to 2 years on work from Dr. Tom Scanlon at the Oregon Health and Science University, and we've generated quite a robust preclinical data set. And so we have data in vivo in several different remyelination models. We also have data in the ABCD1 knockout mice, and we have data in patient fibroblasts from AMN patients showing that our compounds can actually induce ABCD2. I'd just like to end on this slide, which is that the slide that depicts our development path. And what you can see here is our phase 1 studies should be initiating fairly soon. This is going to be a fairly traditional single ascending dose followed by multiple ascending dose. And then we plan on starting a phase 1b AMN patient cohort at the end of next year. So thank you very much for your time. I really appreciate it.
Great, thank you. I'm sorry I got to cut off people, otherwise we won't get through. So let's go on with Ashwara Therapeutics.
Great. First of all, I thank you for inviting me, Ali, and to the community for giving us an opportunity to speak. I have learned already a lot listening to you. I'm Kannan Rangaramanujam. I am a co-founder of Ashwatha Therapeutics. I'm also a professor at Johns Hopkins School of Medicine. The conflict of interest is handled by Johns Hopkins. Today, I want to share with you our interim clinical results for the treatment of our lead compound, OP101, in severe COVID and its implications for CCALD. I want to especially emphasize the importance of neurofilament light chain in neurological injury associated with severe COVID, and what other speakers have beautifully highlighted. Our company is developing a platform called hydroxyl dendrimer platform that specifically targets inflammatory and neuroinflammatory cells in the brain, retina, and everywhere else. Over the last 15 years, collaborating with Sujata Kannan, Ali Fatemi, and many others at Hopkins, we have validated this platform in more than 30 models in 6 species, including human cells and monkeys, with extensive non-dilutive funding. What is exciting about our dendrimer platform is that it is highly non-toxic, even at 1000 mg per kg. And if a conjugate doesn't go to the target cell, it clears intact through the urine, even in humans. So again, we have a significant payload, and this specific compound, we have made multiple GMP lots at 1 kilogram each. As we were developing compounds for neuroinflammation, COVID hit, and we thought that it would be a rather bold but an interesting strategy to validate our inflammation targeting. As you know, the consequences of a virus attacking a macrophage and activating it downstream from that are very similar to LPS-induced insults in many neurological models. And we have shown that OP101 is highly potent in many facets of neuroinflammation, addressing cognitive deficits and other things. So we were pretty excited that if we could actually show that our compound could attenuate or treat severe COVID, it would be an important proof of concept. So even though it was a bold challenge, you will see that it actually paid off reasonably well. So before going into the COVID trial, in anticipation for a CCALD trial, we had already shown that OP101 was safe in healthy volunteers, whether given intravenously or subcutaneously, even at about 40 mg per kg intravenous. So we first wanted to see in a phase 2 trial called the PRANA trial, and the interim results were released, top-line interim results were released last week. We showed that the compound was, so this trial had a single dose of our compound at 2, 4, or 8 kilogram per kg, and the single intravenous dose combined and compared against placebo that was standard of care. So our results showed that, I mean, again, you know that at the time COVID hit, there were close to 300 to 400 treatments for COVID that came about. So we did not allow antibodies like Toci because they were directly addressing it, but we allowed steroids and remdesivir and everything else in the placebo patients and our patients. So our studies showed that in compared to standard of care, which showed a survival of 42.8%, the OP101 following a single treatment in hospitalized patients, severe COVID patients, actually produced a survival of about 82%. Even though our trial had 6% per cohort, so we could analyze the data combining all the OP101 treated patients, which were 2, 4, and 8, so about 17 patients. Even though this by itself did not allow a statistical significance in survival, the magnitude of the improvement in survival has so far not been matched by other therapies in this particular case. What we also see was that in blood biomarkers of inflammation, such as CRP and IL-6 and other measures, a single dose of OP101 containing 1.6, as little as actually 0.4 milligram per kg of NAC, not only reduced the inflammatory markers, but it sustained them for 30 days. Interestingly, to what other speakers spoke about before, was that neurofilament light chain was highly elevated in standard of care patients in severe COVID, and it was completely shut down and was maintained at healthy control levels in patients who got OP101. Of course, the compound was very well tolerated. And what we were excited about was that a single dose at such a small, like, you know, that famed antibodies were given at a much higher dose than what we gave in here. So what we feel is that this is a significant and important proof of concept that we can not only treat inflammatory, target inflammatory cells, even in the context of hyperinflammation following a single dose, we could actually bring remarkable changes to attenuate neurological injury in severe COVID patients. So coming back to CCALD, our group has been collaborating with Ali Fatimi over the last several years at setting up this platform to bring this therapy for CCALD. And we show that in patient cells, this compound OP101, which is dendrimer NAC conjugate, played a important role in attenuating inflammation and glutamate levels in patient-derived VLCFA excited macrophage monocytic cells. So we are quite excited about the prospects of our platform and also this specific compound in CCALD. First, we know, and we have been learning from this community, that neuroinflammation, blood-brain barrier, microglial activation are important markers of CCALD. Now we know blood biomarker NFL is a key component too. So we have shown in many animal models, in pediatric brain injury models, that a single dose of OP101 can do a very good job, and it is safe. And recently, in the interim results with severe COVID, we showed that we could do the same thing to a great extent in humans. And we are excited about it because on the same day our press release came out, there was a paper in Science Translational Medicine that showed that none of the existing therapies, including antibodies, treated NFL or the neurological consequences of severe COVID. To our knowledge, this is the only therapy that treated neurological consequences of COVID with a single dose. So we have a standing phase 1/2 trial that is approved by FDA, and we are looking to raise funds to make this go. So thank you very much for all that you do for the orphan drug and orphan disorder and CCALD community, and for teaching us the importance of bringing therapies to this group. I'm happy to take your questions.
Thanks, Ganna. Why don't we move on, because I really want to make sure that everybody gets a chance to talk and then go to the questions. So let's see, I was saying alphabetical, I'm trying to remember. I guess after Amy, I think it's Minorix, right? Sorry, I forgot my ABC. Somebody from Minorix here?
Okay, sure, I'm here. Over,
Yeah.
hello.
Did I
hope
skip
you
anyone?
can.
I don't think so, right? No.
I hope you can see me and hear me. Good evening from Switzerland. Okay, so I'll share my screen with you, and I hope it's going to work. Just a second.
And as you know, Wolfgang presented the study results for the advanced study, and there was actually a question by the audience about when the company is considering FDA approach and so on.
Okay, so I could just stop here and give you the answer, but first, so thank you. And I'm aware that Wolfgang gave the talk, and I just wanted to go over briefly maybe what Wolfgang hasn't shown or others haven't seen so far. What is MIN-102 or leriglitazone with generic name? It's a PPAR gamma agonist. It's the metabolite of an approved drug to treat diabetes, which is pioglitazone or Actos. And actually in diabetic patients, this metabolite leriglitazone or MIN-102 is already the main contributor to pioglitazone's efficacy. But we chose it over pioglitazone because it has a better brain penetration and has less complicated metabolism. And you cannot achieve the exposure required to treat AMN with the with pioglitazone. You cannot just get a prescription of pioglitazone. It would afford a 5 to 10-fold higher dose than the highest dose labeled. We conducted this phase 2 study, a 2-3 study in the US and Europe. It was, to our knowledge, the largest patient study ever. We had 116 patients randomized. It was a 2-year double-blind treatment. And patients completed week 96 or 2 years were eligible to enter the open label extension. And we actually have quite a few patients continue in the open label extension phase. Now, this is a bird's eye view that you will have seen from Wolfgang already. The primary endpoint was changed from baseline in 6-minute walk test. Now, in the overall population, it was numerically better than placebo. However, when we split the patient population to early onset, that means those with 10 years or less of onset of myelopathy symptoms, it became actually statistically significant, and also the difference to placebo was clinically meaningful. What we were intrigued to see is that it had a very marked effect and statistically significant effect on various parameters in body sway. That is a measure that measures balance, and you can see that here. So we tested it in 2 conditions, feet apart and feet together, and we looked at total amplitude, that is any excursion into any direction on the force plate, but also separately into the mediolateral and the anteroposterior axis. And here in these various conditions, you can see that we actually have highly significant results in favor of drug, also some suggestive trends in the feet together anterior posterior position, and also here in total amplitude in the feet apart, that is this condition here. Also interesting trends in 2 comprehensive assessments, SS-PROM and EDSS, particularly in the EDSS step that counts the overall disability. And what I'm going to show you next is it seems to attenuate the progression of cerebral lesions. We also had some numerical or trends in global assessment. And what is also interested is that significantly more patients on placebo required an upward change in walking aids during the 2 years of double-blind treatment. But this is the results here from the MRIs. So you see we had 6 cases of cerebral lesion progression that were reported to us by the sites while the study was ongoing. So the sites controlled MRIs yearly. And we also had 2 central readers blinded to any treatment allocations. They were just looking at the MRIs and nothing else. And both the sites and the central readers reported that 6 patients on placebo progressed, but none in the active arm. 4 of these patients progressed to inflammatory lesions, and 2 of these 6 patients had growth or incidence of non-inflammatory lesions, and that difference becomes highly statistically significant. Also, when you look at LERS scores, for you who are not familiar, this is a measure of brain lesions. You see that there is clearly a significant advantage of drug over placebo in the evolution of LERS scores. And this is shown here. This is changed from baseline. Red graph is those patients on placebo, and green are those patients on drug. And you can also see that there seems to be a slowing of growth of lesions. In terms of safety and tolerability, no surprise, edema, weight gain, and also increased lacrimations are the most frequent adverse events. This is known from the class of PPAR gamma agonists. However, what I wanted to show you is that, first of all, weight gain here, this is the active group during the double-blind phase. You see that the weight gain is actually more rapid during the first half year of treatment, and then it tends to stabilize. Placebo patients had some weight gain during the study. Actually, the maximum weight gain was comparable between treatment arms. And of course, when the placebo patients were converted to active, they also grew weight. However, during this phase here, you can see that actually weight gain tends to stabilize. And you may argue that this is just because of dropouts for weight gain, but we have checked the data and can say that this is not the sole influence on this. So apparently there is some adaptation, and it can be managed with dose reductions of the drug. So, and we kept the majority of patients on drug in spite of some weight gain from baseline. We also have a second study ongoing, which is a study in boys who have early cerebral lesions, either inflammatory or non-inflammatory. Entry criteria are boys aged 2 to 12 years. It is an open label study. And we look at 2 time points, first of all, week 24, and then another time point at week 96. Whether there is disease arrest. And disease arrest is defined as a composite of MRI and clinical parameters. The study is flexible, so it is compatible with standard of care. That means if transplant is necessary, it will happen. So we are not hindering patients from doing that. We try to reduce the burden of travel by home visits and travel assistance. And you can see the graph here. So we have actually the same layout also of safety visits as in the previous study. Now this study is only open in Europe currently in sites. However, we give travel assistance to international patients. So we had one patient traveling cross Atlantic already, and the sites are open and they are accepting patients. And this is all that I wanted to say. So to just preempt answering the question, what are we doing now? Now we are currently in the final phases to compile the documentation for regulators, both the European Medicines Agency and the US FDA, to show them our data on AMN. We have a clear view on what we think the drug can do. And once we have the view from the regulators, we'll let you know. So next 3 months, I think, will be very exciting times for us. Yeah, that's all that I can present, and happy to take questions at the end.
Okay, great. Yeah, why don't we move on and then hopefully we can come back. I haven't seen any questions yet. Yeah, I guess next is Poxel. Dr. Moller.
Hi, Ali. Thank you very much, the ULF organizers as well, for inviting us to participate. Really good discussion so far. Can you see my screen okay?
Yes.
Great. Okay. I want to go through a couple of programs that we're actively pursuing now for ALD and AMN and give you an update. I think we're really excited to participate in this community and to bring some new molecules into the clinic very shortly. We have two different technology platforms that are illustrated on this slide, both of which have potential to affect multiple parameters related to disease, including fatty acid metabolism, inflammation, etc. One of those two platforms we refer to as our deuterium stabilized thiazolidinedione platform, closely related to pioglitazone, as I'll show you, and also to laraglitazone. The second one is quite distinct. It's a different biochemical mechanism referred to as AMP activated protein kinase, or AMP kinase, which is also a very interesting target for this disease. For both of these platforms, we have clinical stage molecules that have already been in clinical development for healthy volunteers as well as other disease conditions, where we've treated at least 150 or 200 patients so far with good safety for both of the lead molecules. I'll go through the deuterated thiazolidinedione approach first. So as I mentioned, these molecules are closely related to pioglitazone, and we refer to them as TZDs. Pioglitazone, as you can see from this slide, has effects through PPR gamma, as Uwe described, but it also has effects through other pathways that we refer to as non-genomic pathways. Our molecule prefers the activity through the non-genomic pathways and has minimal activity on PPAR gamma, and therefore has much reduced potential to cause weight gain or edema, but we believe still has strong efficacy potential. And you can see here that laraglitazone, as Uwe described, is very closely related to both pioglitazone and to our lead compound 065. Laraglitazone being more like pioglitazone in that it still works very predominantly through PPAR gamma, and less like 065, which, as I mentioned, works through these other interesting pathways. The other approach is the AMP kinase activator approach. This is a very interesting enzyme that's present in almost all cells in the body, in particular in neurons and other tissues, that can be activated by things that are generally good for you, like caloric restriction or exercise, and inhibited in general by things that may be bad for you, like overnutrition and inflammation. It not only affects multiple metabolic pathways and stimulates fatty acid oxidation, for example, but also actively reduces inflammation and may also reduce cell death, especially neuronal cell death, in a number of previous publications. So when we look at these two different approaches relative to the pathophysiology of AMN and ALD, we believe that we have the potential to affect multiple components of the pathophysiology, including modulating fatty acid metabolism, improving mitochondrial function, anti-inflammatory effects, and reduced cell death of neurons. So I'm just going to show you a snapshot of a couple pieces of data that we've generated over the past few months in collaboration with academic leaders, and also a little bit more of the rationale for each of these two approaches. So for the TZD approach, as we've been discussing, pioglitazone has beneficial effects in preclinical models. Obviously, laraglitazone also has beneficial effects both preclinically and clinically. And it's also interesting that efficacy can be achieved in the knockout mouse, the classic model of AMN and ALD with pioglitazone. Our molecule 065, our lead molecule, as well as some of our next generation molecules, have a pronounced ability to suppress the long chain fatty acids that build up in the patient derived cells, as well as increasing ABCD2. That's an additional mechanism that Rohan described in the context of the thyroid beta receptor agonist that we believe could be beneficial. And in vivo, in the animal model, we see a nice reduction in VLCFA in the spinal cord, which could be particularly relevant to the disease state. In the other program, the AMP kinase activator program, we have a pretty similar profile, and there's also an additional rationale for this approach in that the mechanism has been linked both in preclinical models as well as in tissues from patients to this pathway. AMP kinase has also been implicated that it could also induce ABCD2, which could be one of the mechanisms by which it might be working. And in our hands, in the preclinical models, we have a very nice profile as well in terms of reducing elevated VLCFA levels in the patient-derived cells, increasing ABCD2 and another protein called ABCD3. And in addition, having a similar effect, as I showed you on the previous slide, in the animal model, where we can reduce spinal cord VLCFA accumulation. And I should also mention there's additional neurologic benefits in the animal model with both of these two approaches. So basically, to summarize, what we have are two new oral agent classes, the AMPK class and the TZD class, both of which we believe have strong potential utility for ALD, AMN. We're going to initially pursue AMN. And as I mentioned, we have lead molecules for each of these two approaches that have demonstrated clinical safety and in some cases efficacy as well for other diseases. So we're very excited about the opportunity and the potential to take one or both of these approaches into the clinic in the course of the next few months. And we're actively planning for initiation of clinical trials, initially focusing on adult men with AMN in the coming few months. So I'll be happy to take any questions later on. Again, thank you so much for your attention.
Thanks a lot. Thanks for keeping in time. It's perfect. All right, Poxel following by Swan Bio. Asif, are you there?
I am right here.
Hey, go ahead.
Let me share my slide. Give you. Good afternoon, everyone. This has been an informative event for me, and I want to thank Ali, Bob, Keely, and ULF team for the organization. Thank you for providing me this opportunity to speak with you. It's a true pleasure. I'm Asif Packer. I work at Swan Bio. Swan Bio is I can go to the next slide, give you a minute and make it go. Swan Bio is a small biotech company based in Philadelphia, where we are developing gene therapy, AAV9 gene therapy for AMN. And I'll give you a quick introduction to gene therapy. Genes are made up of DNAs, which are blueprints to build proteins that make our body work. For example, ABCD1 protein that's built by the gene affected in ALD, and this protein helps break down very long chain fatty acids. Gene therapy introduces a working version of the faulty ABCD1 gene into the cells. This is done by using a vector, which is often derived from a virus, but the viral genes have been removed. Only the therapeutic genes are delivered into the cell. The modified cells then produce the protein that was missing or defective prior to the treatment. The vector, now if you can look at the right side of the slide. Let me get my, so this is ex vivo gene therapy here. So the vector can be delivered outside of the body, ex vivo treatment, or vector can be injected directly into the body, in vivo treatment, depicted on the left side of this slide, on this side of the slide. Now, for the sake of time, I'll only focus on in vivo gene therapy. Ex vivo gene therapy is what the Bluebird Bio uses for treating the cerebral form of the ALD. AAV9 vector, carrying the working copy of ABCD1 gene, is injected directly into CSF, the fluid that surrounds the spinal cord and brain. With this injection, AAV9 vector will deliver the functional copy of the ABCD1 gene to the cells of spinal cord, and this will provide cells the opportunity to produce healthy ABCD1 protein to slow or stop down the AMN disease. I'll skip this slide and I go directly to here. A team in Boston tested the AAV9 gene therapy in the mouse model of ALD. After the treatment, the healthy ABCD1 gene was observed in the cells across the whole spinal cord of the mice. And you can see those with, I think in this slide is with this brightness is difficult to show, but you can see in these pictures, the ABCD1 gene is depicted in the tissue. But more importantly, this led to reduction of very long chain fatty acids. And if you look at this graph here, where on the y-axis are the very long chain fatty acids, and you can see a change, a drop with a change in or drop in very long chain fatty acids with this gene therapy product in this mice. This work prompted us to develop the gene therapy for AMN. Our program has two types of studies. The treatment study, where we will investigate the AAV9 gene therapy. Currently, we are completing animal studies needed to start the first in-human study. And I'll reach out to you once we are ready to enroll patients in this study. The second study is the natural history study, which helps us understand the progression of the AMN disease. This will also help physicians and regulators to decide about the efficacy and safety of gene therapy. This study has been started earlier this year. In Europe, this study is ongoing in Amsterdam, and if you're interested, you should contact the Amsterdam Medical Center team. Germany will soon start enrollment. In the US, this study will be conducted in Stanford, Utah, Boston, and Baltimore. And these clinics will be ready to enroll in the fall of this year. In addition, we, in collaboration with Autobahn, are developing patient-reported outcome measures with the University of Rochester. This will be an AMN-specific endpoint that could be used in the future clinical trials of AMN. It will help us show the efficacy of a drug using or enrolling a fewer number of patients. So with a smaller clinical trials, we can show the efficacy and earlier in the time too. It will not only be this endpoint or outcome measure will not only for gene therapy study, but for all treatment studies. Keep an eye out for calls from University of Rochester. They will reach out to you through United Leukodystrophy Foundation, ULF, or ALD Connect. Thank you, Ali. Thank you all. I'm happy to take more questions.
Great, thank you. I just got a note from Keely that she was able to negotiate a little more time for us. So we don't have a hard stop at 1 p.m., but let's try to still finish at least the presentations, and then we'll have some time for questions. So let's see, the next, I guess last but not least is Viking Therapeutics. Go ahead.
Hi, everybody. Thank you. All right. Are you seeing my screen okay?
Yeah, it's not in presentation mode, but we see your screen.
Okay, let me get that picked up, please. All right, good. Do you have it now in presentation mode? All right, so hi everybody. My name is Dr. Joel Neutel. I'm the Director of Research at the Orange County Research Center in Orange County, California. And I wanted to thank Dr. Fatimi and the Foundation for allowing us to participate this morning. I recently completed some of the studies in the phase 1 studies of the drug that I'm going to discuss today. And I do that we did this as a consultant with Viking Therapeutics, who is a biotech company headquartered in San Diego, California, that specializes in the development of novel drugs for metabolic and endocrine diseases. Today, I wanted to discuss a drug which I think is a very exciting and novel drug that Viking has recently just initiated a study with in patients with ALD. Now, as you know, thyroid hormone impacts virtually every cell in our bodies. And we now know that the thyroid hormone receptor really consists of two parts. The alpha part, which is stimulated, which when stimulated, really has an impact on the cardiovascular system. And then there's the beta part, which has an impact on lipid metabolism and metabolic control. And when you stimulate that part of the receptor, it results in regulation of lipid metabolism. And we see reductions in LDL cholesterol, triglycerides, and other atherogenic proteins. And it also improves metabolic control. And the drug that we are studying now, and which we just recently completed doing some of the phase 1 studies on, is VK0214, which is a very potent and specific stimulator of the beta part of the thyroid receptor in humans and animals. Now, why is this important in patients with ALD? I think it is well known that in patients with ALD, impaired adrenoleukodystrophy protein function is what contributes to the disease through an elevation of very long-chain fatty acids. And we now know, and there's good data to show, that the family of genes for the adrenoleukodystrophy-related protein seems to be induced and stimulated when you activate the beta part of the thyroid receptor. And this mechanistically compensates for impaired adrenoleukodystrophy protein function, which therefore we believe may reduce the loads of very long-chain fatty acids. And as you can see in the study shown on the slide over here, VK0214 potently induces expression for the gene of adrenoleukodystrophy-related protein in human XALD fibroblasts. Now, when we look at some of the studies that have been done with this drug in the model that was discussed earlier, the ABCD1 knockout model, which, as you well know, mimics the biochemical features that we see in human XALD, you can see from the study that in the mice treated with this drug, there were very significant reductions in the very long-chain fatty acids in the plasma, and also significant reductions in tissue, very long-chain fatty acids, including in the brain. So it does cross the blood-brain barrier. We recently completed a SAD-MAD study looking at various doses in healthy volunteers at our unit, with the primary objective of the study being to look at the safety and tolerability and pharmacokinetics of the drug, and then to look at the impact in the MAD portion of the study after 14 days of treatment on lipids and the very long-chain fatty acids as well. The data that we found in the study was very interesting. Firstly, it was extremely well tolerated in all the subjects that we treated. And as you saw, we treated somewhere in the region of almost 100 patients. In addition, as we expected, there was really no effect on the cardiovascular system, which I think demonstrated how specific it is for the beta part of the receptor. When we looked at the impact on the lipid profile, as you can see in this slide, it resulted in significant reductions in LDL cholesterol after just 14 days of treatment. And that seemed to occur after above the 5 milligram dose. And the reductions were up to about 20%. And we also looked at triglycerides. And here you can see also highly significant reductions in triglyceride levels in these subjects, also after only 14 days of treatment, somewhere in the region of about a 40% reduction. So I think that the initial data from this drug in these healthy subjects was very exciting. Firstly, it showed promising reductions in lipids, including very long-chain fatty acids. They were extremely well tolerated with no SAEs observed. They had a pharmacokinetic profile which would suggest that they can be used as a once daily treatment in patients that are going to be studied in future studies. And as a consequence of this early phase 1 data, we established the doses that we were going to use now in the study, which, as I said, was recently initiated in patients with AMN. here you can see the design of the study that is currently ongoing. It's being conducted in adult males with AMN. It is a multi-center, double-blind, placebo-controlled, randomized study looking at 2 for sure and potentially additional doses of VK0214 in subjects with AMN. You can see that it will be a 28-day study with a 7-day follow-up. And we're going to be looking obviously at safety and tolerability, and then at the change in very long chain fatty acids in the patients that are included in the study. So I think the discussion we had today was very interesting, and I really enjoyed it. And you can see that I think the study that has been initiated is looking at a very exciting and new drug that we hope will come to play an important part as part of the management of patients who have this condition. So again, I wanted to thank you everybody for your attention, for the excellent meeting. I'd like to congratulate the group on the excellent meeting, and I too would be happy to take any questions when we open it. Thank you, Dr. Fatimi.
Thanks a lot. Thank you. All right, great. So we have 10, maybe 15 minutes. I don't see any questions from anyone yet regarding any of the company presentations. But you may want to ask questions. You may raise your arm. You may put them in the chat.
Ali, I see one from Minorix. That is, are we pursuing breakthrough therapy?
Oh, yeah, right.
Yeah, so the answer is we have so-called fast-track designation with the FDA that gives us some privileges for scientific advice. Now, there's always a negative perception from regulators if you miss your primary endpoint. But I hope we have some credit, because when we set out with this study 5 years ago, no one really knew what a sensitive and reasonable parameter was to show efficacy. And based upon interactions with the FDA, we chose 6-minute walk test. Now, what we can say is there was quite a broad range of symptom years in terms of symptom onset of myelopathy. Also, we had quite a few patients with quite long disease duration. And as I said, what we have shown is a clinically meaningful and statistically significant effect in the subpopulation of that. So I hope we can get some credit and consideration by the FDA to say it is not like a classical design where you have had 20 successful studies before, and you can just dismiss a study that missed the primary endpoint. So this is where we stand, yeah.
Ali, I have a question to Viking Therapeutics. I'm missing out doctor's name.
Joel Mutel. Hi.
Hi, John. So my question is about the study design that you showed, and it's about the access of the VK0214 after the study is completed. So after 35 days, when they have tapered off the drug, would AMN patients have access through a long-term study or another study? That's question one. And second, once you go to later stages, maybe a phase 3 study, would the patients who participated in this study, would they be allowed to participate in the later studies?
Yes, I think that the plan is to conduct long-term studies, and I think that particularly if we see the data to be beneficial in these patients, we would have to allow them to continue in those long-term studies. Brian, I don't know if you had any other comments on that.
Yes, it's Brian Leon here from Viking as well. We don't have the tox coverage right now to treat longer than 28 days, but we will. Those studies are underway and aren't expected to. They're going to be completed this year, so we'll be able to in the next studies.
Thank you, Brian. Thank you, John.
Thank you.
Yeah, I might bounce back, Asif, a question. So, you know, with the importance of natural history study, obviously is still, you know, extremely important that we collect natural history data. You know, it's a good problem to have, but I foresee a challenge now that when companies come up with doing this shorter term study, especially, how are we going to get people? So if somebody's enrolled in a natural history study and now there's a phase 1 for, like, say 2 months or 3 months, I guess we have to consider what are we going to do if somebody participated in a phase 1 study. Can they still participate in a natural history study after the phase 1 is completed? Do you have thoughts about that? How are we going to,
Yeah, no, Ali, this is a question for most of the therapies in a clinical trial.
Right.
The way in natural history we address it is that a patient, I mean, they can be on a study, on a trial. That's not, and they would be eligible. That's not very important for us. But it is they have to be on that treatment during this duration of the study. So we want to assess the progression of disease while they are on their baseline or their baseline therapies. If they decide to change, if they anticipate a change during the trial, we'll ask them to wait till that change has happened and then participate in natural history. So let me give an example. If a patient is taking, I'm picking Minorex just because Uwe is here and he will forgive me for that. If a patient is taking the Minorex drug and then they expect to take it for next 2 years, those patients can participate in phase 1/2 study. But if patient is planned to take a Vikings treatment for 1 month, then stop for maybe, I'm picking up 5 months, and then go back to long-term follow-up, that patient would not be a good candidate, because then in natural history, we will be measuring the effect of a drug rather than the natural history of the natural history of the disease. So on and off is not allowed, but a constant or consistent intake is okay with us.
Yeah, I mean, I know when we were doing the Minorex trial, that was part of the challenge, even with the interventional trial, that people's, they were like, okay, I can't sleep. And we were like, okay, let's prescribe this medication, but then we couldn't because that would have been exempting them from the trial. And I think it's going to be difficult in natural history always if you want to like hold off any sort of symptomatic treatment that would be new. So that's something you have to keep in mind in terms of.
I fully agree. So patients with spasticity, I mean, their spasticity continue to worsen. And if for natural history study, or even for treatment study, we do not want to hold off those increasing doses of baclofen or tizanidine. They can continue to increase. And it's also possible that during the study, you want to change the medication for medical reasons. So baclofen, take an example of baclofen. Baclofen is showing some side effects and probably is not the best medication now, and you want to move to tizanidine or a different one, or yoga. And they're able to do that just because this is medically needed, and they should be able to do it. That would be, for us, would be, in most of the studies, it's a principle not only for natural history, but for treatment studies too.
Thanks. I see some conversation going on about measurement of VLCFAs, but it looks like it's addressed. So I don't see any other questions so far. Just raise your voice. It's better to ask now the companies directly than me tomorrow, because I do get these emails all the time. There's a question, what do I have in the Bluebird Bio? Well, they're not here right now, but maybe one of the, Troy, are you still here since your site is part of the study? Can you answer the question? Is Troy gone? Oh, I'm afraid he's gone. So, Dr. Eichler talked about it earlier. So that study, the product for ex vivo gene therapy received approval in European Union. In the US, it's still not approved. It's still investigational. The studies are basically complete. There is an observational group that's being monitored. And I think the company is trying to address what to do in between in case some new kid needs to be treated. And then where can we get enrollment information on trials? Well, maybe I answer that. So clinicaltrials.gov is the place to go if you want to look just in general whether there is any clinical trials for any disease. You go to clinicaltrials.gov and then you type in the name of a disease. Sometimes it can be a little overwhelming. Ideally, your physician should know and give you information. You can also reach out, I guess, to anybody here that is presenting right now if you have interests about their studies. Anybody want to add anything about that? So again, it's clinicaltrials.gov. That's the website. The next question is, what is the estimated population of AMN patients, symptomatic and asymptomatic? Oh boy. Well, it's about, so the incidence data that we are getting from newborn screening is somewhere around, depending on which state you've been looking at, 1 to 7,000 to 1 to like 17,000 overall. Of course, not everybody will go on to develop AMN. Some will be cerebral ALD, and this is males and women combined, females combined. So you can guess it based on the country's population, how big that number is. Again, I'm not, so in the US, it will be, I think, somewhere around 5 to 10,000 people that presumably are affected by ALD. And many of them, of course, are undiagnosed. So that's part of the concern with this disease, why we have newborn screening. Stefan, do you want to add anything?
No, I was also calculating. You have 300 million inhabitants divided by 17,000, and then let's make it easy that half will develop cerebral ALD and half not, which is, well, if somebody's calculating, then that should be more or less the number, but I'm not sure if that's really correct, if that takes everything into account. But yeah, if you take prevalence, that should work out. I think you're right. 2, 3, 4,000, many more than you would need for your trials. But you made a strong point. Many undiagnosed.
Ali, this is not my question, but I have a relative question to this one. How many symptomatic AMN patients get the right diagnosis in timely fashion, and how long does it take to them to go around and I'll come to the right diagnosis, let me put it this way.
I don't know if anybody has really studied that per se. I think Josh Bonkowski has been trying to look at that in ALD or in leukodystrophies overall, but our experience is that people, if they are not having a family history, it takes years for them to get the right diagnosis, and more so in women. And even in families where there was ALD and they somehow forgot about it, that their uncle had ALD, and then they undergo a whole new workup and see 5 different doctors until somebody realizes. So that's unfortunately more the rule than the exception. So. And
has newborn screening changed this by, I don't know, has changes happened?
Yeah, I don't think we have enough data on that yet.
No, not data, but based on your experience or that physician's experience.
Not really. Not yet. I think until we have the whole US covered.
Yes.
So there are some more questions. So there's a comment. I'm not sure if anybody wants to address it. I hope you will allow patients on different diets to enroll in your studies. This is most ethical. Any comments, anyone?
Okay, so it depends on the diet.
Yeah.
Yes. Yeah.
Because if okay, this is not a diet, but if you are using a statin, and the readout of a trial is plasma valine chain fatty acids, you can't participate because the statin will lower your plasma valine chain fatty acids. But it's not because it has an effect on the fatty acids, because it's lowering cholesterol and it's lowering LDL. And much of the C26 in plasma is bound to LDL cholesterol. So by definition, if you have less particles of LDL, so less bounding spots in plasma available, your fatty acids go down too. So that was published in the New England Journal of Medicine in 1998, I think. It's a possible therapy, but we repeated it and we measured plasma valine chain fatty acids, and yes, they go down. But LDL also goes down, HDL goes down, but then if you measure the C26 in LDL, nothing happened. So it was an epiphenomenon. Yeah. And if you're on Lorenz oil, you can also not participate in the trial that looks at plasma variant chain fatty acids. So it depends on the diet.
Yeah, Stefan, this is David. I just thank you for bringing that up because it's something we all have to keep in mind, especially those of us that will be looking at VLCFA levels as a potential primary endpoint in our earlier stage studies. And it's good. We need to be looking not just at the plasma levels, but also at the cellular levels if we can. On the question related to diet, my understanding is, I'm not at all an expert, that diet is not usually a big influence on VLCFA levels unless you're on a very high intake of peanut butter or something like that. So that's what we've heard. And so we would intend to try to include as many patients as possible on as many diets as possible. But, with the caveat that we want to monitor dietary changes in diet. They should be stable, hopefully. But if they're suddenly going on a long-term fast or switching to a ketogenic diet, that could create an issue. We don't know. And therefore, we'd like to, at least be aware during the study of any major changes in diet. Does that make sense to those of you that are experts?
Yeah,
that makes sense. And that's what our point would be, that if they want to be on a diet, they should stay on that diet during this duration of the study. It doesn't matter what diet they're following as far as they stay stable on that. And to Stefan's point, I mean, all studies do have some criteria, some prohibited medications or things, depending on each drug's mechanism of action and some of the outcome measures they're looking at. So that question about which medications are allowed or not depends on the mechanism of the drug or the study they're in.
Well, the statin was simply an example of something that we found out that we know, because I see that somebody says AMN diet and somebody doesn't agree with my statin. It was an example. And it says AMN diet, but I don't know what AMN diet is. So if some people interpret AMN diet as Lorenz oil, then it's the same thing. So,
answer for Minoric. So we currently have no studies open for adult male patients with AMN, but in the past study, we haven't made any restrictions for diet. And also the study in boys doesn't have any restrictions for diet.
And with the Viking study, I think we've tried to remain as real world as possible with exactly the things that everyone said. Obviously, there's some drugs that may impact the one that you're studying, and then you have to exclude. But other than that, or diet issues. But other than that, be as real world as possible and standardized, like you said.
Mm-hmm. Okay, thank you all. There's some more questions. I'm not quite sure what this question means, but given market mania in the United States, do any of these companies have plans to go public via traditional IPO or SPAC? I had to Google SPAC, what that means. Special Purpose Acquisition Company. Anyone who wants to comment? I guess at least one of you is already public, right? Isn't Viking public already, I think?
Yeah, Viking's public. And we are public. Poxel is public in Europe, potentially could go public in the US in the future. So we're all looking for money. And if going public or having some merger via a SPAC is a way to get money and it makes sense, then we might do it.
And then there is a very good question by Christy DeMarco. Could some of these therapies that reduce very long chain fatty acids have application for Refsum disease where they can't break down phytanic acid? I would say if there are MBCD2 inducers, probably. I don't know, Stefan, you have thoughts about that?
Oh, sorry, I'm answering a question.
Oh, okay.
Can you repeat the question?
The question is whether any of these drugs could be helpful to bring down phytanic acid and Refsum.
Oh, yeah, I've seen that one. That's a different pathway, yeah?
Mm-hmm.
So I don't think so. But it depends on the mechanism of action. But I haven't seen any of them.
I guess if you massively increase peroxisomes by peroxisome proliferation, you should have an effect, right? So
yeah, 4-phenylbutyrate.
4-phenylbutyrate, but not.
With 40 pills a day.
Right. Okay.
No effect.
So I'm just seeing there's some comments, but I wanted to see if there's a question. There is a question that's important. How much sharing of data is there between industry members with each other and with researchers?
The answer is not enough.
There was an earlier effort this year that we're working with UVE also to commit to share the control data or our natural history data to everyone in the public through a third party, and third party being ALD Connect. So we're working with ALD Connect to set up a data set or a mechanism through which we can share the control patient data or natural history data with all industry members. I think once we have any update on that, we'll share that.
Yeah, just to confirm, we are still on board and interested, so we should catch up soon, huh?
Yes, we are too. We'll do that.
One idea that just crossed my mind was the possibility of doing some pre-competitive experiments to look for additive or synergistic effects with different molecules combined in for example, in the knockout mouse. If there's a standardized way to do that, and somebody can maybe write a grant and work with us to do that, I think that would be a really interesting idea.
Yeah, I'd be in for that.
Okay.
As you know, I'm an advocate of considering combinatorial approaches.
Yeah, let's maybe talk about that in the future.
Yeah,
we're happy to share our molecules, but we don't necessarily have the money to do tons of additional experiments.
Excellent.
There's lots of thank you comments. So I appreciate all the companies presenting here. There's one I guess comment / question by Luann is about the discussion raises ongoing issues make me wonder how we can more fully educate neurologists, endocrinologists, pediatricians in general recognizing symptoms, especially newborn screening gaining ground. How can we educate them more? Conferences like this for them. I'd like to say that one of the companies a few years ago organized during the Child Neurology Annual Symposium. So there's the Child Neurology Society, and that's where 2,000 American and Canadian child neurologists go to every year, except last year because there was COVID. And one of the companies organized a session on ALD to educate child neurologists on ALD since newborn screening is being implemented. That was, I think, 3 years ago. And I think Keith Van Haren and I went there to present. And there was one physician who came over to attend that free session that had food included. So I was very disappointed that nobody showed up. So, does any of the companies have any ongoing efforts in educating the public or advocating within, American Academy of Pediatrics and other organizations?
And I see the need there, but we do not have a program at this point. And Swan Bio is a very small company in early stages.
I know
it would be typically for pharma companies, and we consider ourselves pharma companies. That kind of activity would usually be, when you have a product about to be or on the market, you're trying to really broaden the awareness of the disease beyond the people that are really part of the community of the affected patients. But it's a great idea, but we just can't afford to really do a lot of that kind of stuff.
Well, I thought Bluebird had a support program. Too bad they're not here to answer that question, but they have it. But obviously they are now in the market, at least in Europe.
Yeah, that should help raise the awareness outside of the immediate circle.
I think adult neurologist or AMN is something where there's a large need, and I think that I haven't seen the Bluebird Bio's program in detail, but that would be probably for cerebral disease in pediatricians and pediatric neurologists. But I do not know the details for that.
Okay, I think we're 12 minutes over. Thank you all. Thanks for sharing your product information and your programs. Thanks for everybody attending. Keely, are you still there?
Yes, I'm still here. Thank you so much, everyone, to all of our speakers, our presenters, our industry friends, and everyone that is on the call with us that's asked amazing questions. We do want to give a quick shout out. The next session that actually is should be playing right now, but the meal break, the messages from our industry partners, it also includes the ULF Legacy and Service Award winners. So please check out those videos. We have two amazing award winners this year. We're so grateful for their work for the community. And if you don't happen to catch that session while live, please check out our Facebook page, and then we'll post the videos to our ULF website as well. But thank you everyone that has participated today. Hope you enjoy the rest of the weekend, and we hope to see you next year.
Very much, everybody.
Thanks, Keely. Thanks, Ali.
Thank you.
Bye-bye.
Goodbye. Thanks, everyone.